Good morning. Good morning, Honorable Governor Bryant, cabinet members, any members present of the 35th Legislature. Thank you all for your support and participation in what promises to be a dynamic summit. Greetings and welcome to the Virgin Islands and the second annual Digital Health Summit, brought to you from the Office of Health Information Technology. A special thank you to our speakers, our presenters, our panelists, our medical provider community. Thank you to our sponsors and exhibitors for helping to make today and the rest of this week possible. And a special thank you to all the staff and everyone who is working behind the scenes to put this on today. Before we go any further, we want to pause to recognize God, our master strategist, the master innovator, engineer, and keeper of our lives, and ask for his blessings, divine guidance, and his God-sized ability to envision, plan, and lead.
Please stand for prayer. Dear God, thank you for giving the opportunity for us to gather here today. Thank you for protecting us as we traveled and providing an opportunity to meet, learn, and grow. As we begin our conference, we dedicate this time to you. In Jesus' name we pray. Amen.
Amen. Okay, so I hope everyone got a good breakfast, got some tea. You'll have the chance to get up and get snacks throughout. We won't take breaks for snacks like we did last year, because we found that sometimes we got really excited about snacks and engaging, which we want you to do, but it was hard to get everyone back. So feel free to get beverages and snacks as you need them. So everyone looks really eager and ready to engage and take away something that will realize positive and consequential impact. I'm Michelle Francis. I'm the Executive Director of the Office of Health Information Technology. This summit addresses all three focus areas of the Office of Health Information Technology strategic plan: to empower patients and providers, to help build health IT infrastructure, and to also help build a capable and resilient workforce. This summit also lives out the mission of the office to serve as the nucleus for innovative and transformative health IT services and resources solutions all across the USVI. Why do we do this? In order to improve the health and wellness of all Virgin Islanders. Over the next few days, you will learn what some of the foremost leaders and organizations are doing in the realm of digital health, data, interoperability, security, and policy. You will learn from clinicians solving long-standing issues through groundbreaking uses of technology, their groundbreaking partnerships, and their ability to break through silos. You'll also learn about an exciting advancement in our efforts to establish our territorial health information exchange, as we have signed a letter of intent with CRISP Shared Services to participate in an interoperability and data set verification pilot tied to US CDI+. So if at this point you're like, US CDI+, what in the world are you talking about? What is interoperability? That's why we have our fabulous speakers. They will unpack all of that for you today. The pilot that we're going to engage in will prove out minimum necessary data elements to build an interoperable workflow between providers and across systems. We learned last year from keynote speaker Dr. Ernest Carter. Dr. Carter, where are you? Doc Carter, welcome again. Doctors Carter. That this summit provides a series of on-time master classes in this ever-evolving landscape. I think after he spoke, everyone was like, okay, give us a few minutes, and took pages of copious notes. It's clear that it takes an entire community to pull off a summit like this. While this summit is intended to help us take away new tools and skills to tackle complex issues, it's also meant to challenge all of our comfort zones. Do it afraid. I'm sure you've all heard this phrase, but it's particularly poignant for this conference at this point in time and for all of us as leaders. When the technology outpaces our standard processes of planning, of change and adoption, we must all wrestle with the call to pioneer and the need to securely and sustainably navigate an ever-changing field of possibilities. We have to also be careful to find and strike a delicate balance of cautious exploration versus our own entrenched thinkings and patterns. This is the way we've always done it. It's very hard for any human to let go of what we've always done. Brené Brown contends that it's not fear that actually gets in our way of daring leadership. It's our armor. When things get tough, do we lean into vulnerability and get curious, or do we self-protect in ways that move us away from our values? Brené defines grounded confidence as curiosity plus the willingness to rumble with vulnerability plus practice. While armor is our greatest barrier to being brave, grounded confidence is the heart of daring leadership. So my challenge to all of us through this summit, as we ride the technology wave, is to ground ourselves in confidence, the confidence not only in our own skills, but in people that are in this room today, and to have a heart of daring leadership. Before our governor comes up, I want to recognize a number of individuals who inspire and work to ensure the success and the reality of this summit. I want to start with recognizing Governor Bryan. Thank you. Chief of Staff Carl Knight, Luigi LeBlanc, who many of you met yesterday, and we discovered that we all have 1 degree of separation from Luigi. The Southeastern Regional Telehealth Center. I hope you guys will meet, where are you, Boyd? Meet Boyd. The Southeastern Telehealth Resource Center supports Puerto Rico and the Virgin Islands. I think they're an underutilized resource, so make sure to talk to him and find out what support your practices, your organizations, your departments can gain from him and from CTEC. Joanne, Eddie, Everney, Eugenie, Miss Eugenie, I can't thank you enough for the 2 a.m. texts and phone calls. It always humbles me when, especially working in government, there's a strange misconception that people in government work the least, but I work with the people that work the hardest and the longest, including in Department of Health and Human Services and across our public health system, so thank you. I also want to thank our volunteers. I want to thank the people that set all of this up. Dana and team, our LIFT program interns, Brad Nugent and his creative genius. Everything you've seen here, you heard the voice, the booming voice calling you in. So Brad and Media One, who's going to make this all possible, I thank you. And again, our sponsors and speakers, thank you very much. I also want to take a moment to pause and recognize all healthcare providers. If you're a healthcare provider in any capacity, would you just stand to be recognized, please? We appreciate you and engaging in the process of change for enhanced abilities to treat the whole person. I also want to thank my boys. My boys are here today, not because I wanted them to sit through a conference and not because they wanted to, but because life happens. And so Ari and Rafa, I want to say thank you for waking up at 5:30 this morning and being here. You guys are mommy's inspiration and the reason why I dream and I do what I do. So thank you. It is now my honor to welcome Honorable Governor Bryan to the stage.
Good morning, everyone. Please be seated. Thank you, Michelle. I always want to jump on the stage, but I know I have to act like a governor and walk around. I have to leave all of my country boy at home. So I just want to say thank you to everyone for coming out. This is our second annual Digital Health Summit. You know, last year was an election year, and thank God that's over. But a lot of things that we did was about getting elected, the things that people really care about. And you know, Michelle used to come to me and she used to tell me about all these things. I'd be like, that's good, but we need to get stuff that's going to get us votes, you know? And she did a good job of making sure it got done. But the whole time I maintained to her that there are so many things that people don't pay attention to that constantly improve your quality of life. Technology is one of those things. But no matter where you are, we don't understand, most people, how technology is influencing and creating environments and helping us all the way. In healthcare, it's more important than ever. I live with someone with a chronic illness, diabetes, and I've been all over the United States for healthcare. And it would always freak me out that you go in with my daughter, the physician never touched her. Never touched her. And I was thinking, why would we have to come all the way here? That's the power of what health information technology can bring to the Virgin Islands. Because over 30% of our people live below the poverty line. They don't have the ability to get on a plane and fly to DC or to Florida to get health care and not be touched. But now, through your help and the help of work of people like Commissioner Encarnacion and Michelle and a lot of others, we're able to get people in touch with physicians, healthcare, information, education, all along the way. Last year's summit was spectacular, and I'm pleased to find so many more new people show up this year again. And we are dedicated to making this happen because for us, it's the unseen things in this community that makes life better. And you don't really get the credit you deserve for it. I remember one day I was talking to a friend of mine just with the influence of technology. And he said, man, I really got to say you're doing a good job. And I said, well, why? He says, you know, I used to take the day off to register my car. And you forget, right? Literally, people would take the day off, get a good book, and go down to the BMV to get their car registered. In the Virgin Islands, you have to get your car inspected to get it registered. He says, last night I registered my car online. He said, I didn't have to go down there. He said, last week. He said, and by Monday, I got the registration in the mail. 8 hours of his day saved by just, for something as simple as registering your car. Imagine the power of healthcare when we are able to collectively put data together to study and look at how can we serve our community better. You know, last year we went to DC and Maryland, and we were exposed to a piece of software and a system that actually can help us do this. I mean, I got so excited when I found out about Chris and what they could do. And then I just thought about all the ways we could start to wire our community together to give people the best health care. But not only the best health care, but the best social care. You see, a lot of the problems in our community are linked to poverty. And poverty is not just an economic situation, it's a mental situation. Because even if you give people the tools, they don't know how to use them. Now, I am so happy to say that we signed a letter of intent and a memorandum that will lead to a memorandum of understanding with our good friend Craig Beam of Chris. Get up here. It is just, you know, this baby steps. It's like, I don't know if you know the Terminator, like when the AI became sentient. It's like that moment. Nobody really noticed it, but it turned around the world. No, that Chris is not going to take over the world, ladies and gentlemen. But for us, it is that important. It is that important to be able to partner with someone who has the experience. And for us in the Virgin Islands, you know, we are blessed in a way that we don't have to figure it all out. This is being done somewhere else before. But I'm glad you're on this journey with us, that you're going to take the journey and be able to help us get to a point where we can serve the neediest of people in our community. I am proud today to say that we have an excellent lineup of speakers. including Dr. Sandra Ford, who I met last night. Thank God it's a little bit cooler than we were last night at Catherine Burke, for those of you who joined us there. We have so much to talk about, and in the Virgin Islands, like I said, things happen so quickly. And it touches you. I mean, sometimes I wish I was the governor of a big state because you have a little bit more anonymity. But it's those good days when, you meet somebody that says, thank you, Governor, for that scholarship, or I got through with the job training that I want. Thank you, Governor, for making sure that we have connectivity in our schools and in our public housing communities, because I didn't have that before. Those are the things that we take for granted. And in the Virgin Islands, this is an amazing time. Just to let you know some of the things that we're doing. I'm trying to be the first digital governor and the best digital governor ever in the Virgin Islands. And health information technology is only a piece of that. Right now, we're making sure that we have connectivity for people and access to at least 5 megabits all over the island for free. So whether you're on a beach or a park, you're in your home, public housing, a school, a library, you can get connected, because it truly does connect you to the world. We've joined the president in making sure that IT is a big part of Virgin Islanders' lives here. I want to tell you, the interoperability of Chris is just the most exciting thing for today for me. And this week, I look at our healthcare services, whether Medicare or through Cigna. We touch over 55,000 people. That's over half of our population here in the Virgin Islands. I want to say thank you to each of you for coming down here, your time that you spent traveling and coming here today to invest it. I just want to make sure that you have a good time. If I met you last night, and if you have any problem, Carl there in the front row is my chief of staff. He's in here somewhere. Take all your problems to him. And please make sure you get a chance to enjoy some of the island while you're here. I got to run. I got to go over to St. John today to cut some ribbons and do some other festivities over there. But I'll be back. I want to have a chance to speak with some of you individually while you're here on island. I'm just really grateful again to see you show up today, and very grateful to Michelle for her leadership on this and the whole team for putting this together. And otherwise than that, I want to say have a fantastic day, and I'll see you later. Thank you.
In respect of the governor's schedule, we've shifted things around a bit, so I know you guys are flexible, and I appreciate that. We're going to show a short video as Commissioner Encarnacion, Commissioner Kazi Gomez, and Director Smith, Karen Shield, if you guys would just come on stage while we show this short video from the National Medical Association president. Then we'll be hearing from Commissioner Encarnacion, who will just give us bring greetings as our Commissioner of Health. And then we'll be hearing a little bit from a dynamic collaboration within the Department of Human Services and the Medicaid program. We can run the video. Okay, while technology catches up to us, I will ask Commissioner Encarnacion to come and give greetings.
Good morning, everyone. First of all, thank you, Michelle, for putting this on, for getting everyone together. And Governor, I always really enjoy listening to you. You take something up, but you never read. So that's always impressive. I love your love for the digital, for IT, and what we're doing right now. But let's talk about interoperability. Can everyone say that? Say it louder. So let's take that and connect it with everybody in this room. Because that doesn't work if we are not all connected, true? So what we do now is we take the data that we're actually going to be sharing with each and every one of us through portals that, like Chris said, the governor spoke about. I'm very happy. I was very impressed with what you had to offer. So looking forward to what we can do with that data. But once the data comes to us, what do we do with the data? We have to make changes. We have to create changes with that data. So my staff, and we will be speaking with you throughout the conference, talking about public health, talking about what we do in public health in reference to solving problems from a public health standpoint, also from a global health standpoint, population health. What do we do? How do we focus on a group of individuals? How do we focus on one person? I have my team from Disparities here, my community health workers, AC Malloy, who will be speaking with you a little bit more in terms of what we're doing with the data warehouse. There's so many things that's happening right now, but coming together and having that conversation and making things happen is what I think we do best. And that is just that collaboration, fostering relationships, and growing. Public health means everything to me, means everything to us. I'd like my staff, my team, everyone from the Department of Health to please stand. Thank you all for all that you do. Michelle, thank you for having me here to be able to say good morning to these beautiful people. As my Assistant Commissioner always says, good morning, beautiful people. It is really and truly a joy for me to be here. Thank you. Please enjoy the day, enjoy the couple of days, and enjoy the island.
May have to stand up here. Good morning, my name is Karen Shields, and I'm the Chief Client Engagement Officer for Gainwell Technologies. And so what Gainwell Technologies does is not enough in the USVI. And so we are here to commit to more investment, to pay more attention, and to be more present here for the work that you all are doing. I've been at Gainwell for a year. I was previously at the Centers for Medicare and Medicaid Services, where I met Director Smith. And those of you who know him know how dogged he can be and how just loudly and aggressively he advocates for the USVI and all the territories. And it works. It worked. From the beginning of his relationship with the Medicaid department at CMS till now, a lot of strides have been made. But I understand that we are not where we want to be, but we're not where we used to be. And so in my role at Gainwell, I'm committed. I am a member of the C-suite, and I don't say that to brag. I say that to say that we are here. And I represent the leadership of Gainwell Technologies that has responsibility for claims payments for over 30 states, and to whom much is given, much is required. And so we are here to, and I am here, and the Gainwell team is here. The Gainwell team, you want to stand up? Yes. We are here to represent that intentionality because there is an amazing amount of opportunity with the population that you are currently, that you all represent and that you all serve, for the United States to take a more intentional financial interest in designing pilot programs and knitting together, like the commissioner said, the people with the data, because there are stories that are untold in that data that just can't lie dormant for much longer. We got to get them up. And in my role at CMS, I tell people all the time, the shame I take with me into private industry was my inability as the director of the Medicaid systems for all 50 states and 10 territories, my inability to tell the stories accurately about how COVID was impacting the most vulnerable population in our country. We were guessing, and that is unacceptable. And so I personally am here to make sure that I meet anyone who needs to have some good information about how the federal government can and should help you more. That's my superpower. And so I bring that here to anyone who is interested in having that conversation with me. I am honored and blessed to be here, both with Commissioner and with Director Gary Smith, to be able to do all the good work. And I will leave at the end of the week as an advocate and an ambassador for all that is needed here, and will continue to always be a big fan. All right? So Gary, I'll turn the mic to you. Yeah, you may have to stand up here. I guess so. Sorry. That's okay. Yeah.
Morning again, everyone, and welcome to our beautiful island and the beautiful Virgin Islands. Those of you who know me, as Karen said, you know, I always talk about my island. I brag about it. But in the Medicaid space, you know, the challenges that you experience, we experience here as well. And our business is to ensure that the most at-risk, vulnerable populations have access to health care. And, you know, I spend every day, you know, I wake up in the morning looking forward to go to work. I've never had a morning where I did not want to go to work. And then leaving, you know, putting in 12, 13 hours some days, you know, it's just ongoing. But, you know, I'd like to to speak to the strides that we've made. It would not have been possible without my staff, my hardworking staff, that where we are very short as far as staffing and resources, and I'd like to recognize them. I do know that there are a couple of them here in the room, and I'd like them to stand to be recognized. So, Commissioner, you know, we would have more here, but they're back at the office doing our work, right? Saving lives and making sure that people have access to health care. You know, I'd also like to thank our sponsors for partnering with us for this event. I think it's very important that they get to come and see and experience our culture, so that, you know, they are invested. We need and are looking for vendors that are invested in what it is we're trying to accomplish here. And I always share that with my with anyone that we have a conversation with when it comes to wanting to come and help us. You know, we want the partnership to benefit our Virgin Islanders and also our other territory colleagues, brethren and sistren in the Pacific Islands, and also the Puerto Rico right next door. I'm so passionate about that because I represent 5 U.S. territories on the National Association of Medicaid Directors Board, and I take that responsibility very seriously. So whenever I speak about the Virgin Islands, I'm also speaking about the other territories as well. Commissioner, I'd like to thank you for your leadership. You know, without you allowing me to do what I do, you know, it wouldn't be possible for the achievements that we've made. Gainwell, Karen, thank you very much for the kind words, but then also committing that Gainwell is going to commit to do more. We have had a relationship since 2013, and, you know, we're looking forward to continuing that relationship, because right now we have before us implementing provider enrollment application, which will, for the providers that are in the audience, you know, it will operationalize the enrollment of your application, so no more paper. It will streamline that process, improve on our claims processing, improve on our error rates as far as denied claims and claims with errors. We're also going to be working on implementing electronic visit verification. So the personal care attendant services program will improve. We'll be able to possibly offer that 24-hour service that a lot of our citizens want and require. But before we can get to all these things, we need to be able to implement these new technologies and enhance the Medicaid management information service. So I see Brad there gave me the signal. So my time is up. I'm going to pass it on to Commissioner so she can make some remarks. Thank you, everyone.
A minute for the governor. Bye, Governor. Good morning. Pleasant good morning to everyone. Kimberly Causey Gomez, the Commissioner of the Virgin Islands Department of Human Services. It's always nice to be at a place where we're all like-minded and we're all in the same place. Director Francis is an amazing spirit. What I love about her is her innovation and creativity and the ability to bring everyone together. And so for me, that is an amazing feat. I wanted to tell the story while the governor was still here, but during the last cabinet meeting, our governor had this brilliant, as long as with his team, that we would get our biometrics done by Cigna. So we all lined up and we all got our biometrics done. And I'm thinking, Kim, you're pretty fit. Like, you eat well and you hike and you do stuff. And I get my results back and my cholesterol is high and my blood pressure is right at that cusp. And I was like, you know what? This is not a good thing, right? So I send it to my mom, and my mom looks at me and she said, your grandmother had a stroke when she was 45 because of cholesterol. And I'm not very happy with these results right now. So what are you going to do to change it? So the mindset for me is, what am I going to do to change it? There's so many people in our territory that are living in poverty, and I'm so glad that the governor brought this up, because there is a benefit cliff or a fiscal cliff. So if you're in a state of poverty and you're living and you're getting all the eligibility programs, whether it be SNAP and Medicaid, childcare, as soon as you start making a little bit of money, then your benefits are now taken away and it puts you right back into a poverty state. And so that cycle for us is what we as a territory have to break. What are we going to do together to make sure that people have access to everything they need, not just healthcare, but food, basic needs? Because the food insecurity is very real in the Virgin Islands, and that goes back to preventative health. If your diet is not good, you're not doing preventative health. And that's the governor's initiative as well, is to be active. How are you doing well? So I look at it from those terms. I'm very thankful to be in this position and privileged to be able to serve the people of the Virgin Islands and be able to do this. So as a team, and Director Smith's leadership under Medicaid is one portion of it, but I'm so thankful for his tenacity, because he is very tenacious, if you know Director Smith, and so thankful to Gainwell and Karen being here and all of you. So as we move forward the next couple of days, let's make sure that we network, we come together, don't work in silos, because in real is that holistically, it is one person, but they have multiple needs. So how do we do that together? So welcome to the Virgin Islands. I'm so thankful for all of you being here. Thank you for having the Department of Human Services rep. He's already thanked everybody, but I'll thank them again. So thank you, Gary. Thank you so much for the work that you do every day, and those 13-hour days. And the text messages at 11 and 12 too, yes, we get all of that. But most of all, I think the next steps for us are going to be really important, so action steps and timelines. So as we do that, let's make sure that we move in the right direction. So enjoy your next couple of days, and I look forward to meeting you.
thank you all. I think it's important, even though so many of you have flown in to share, I think it's important for you to also be able to hear kind of from our local leaders and what we're doing and what the needs are here. So thank you for sharing. It is my privilege to be able to welcome to the stage Dr. Sandra Ford. Dr. Sandra Ford, MD, is a board-certified pediatrician. She's served in a variety of leadership roles, most recently as the Special Assistant to the President for Public Health and Science in the White House on the Domestic Policy Council. Dr. Ford's portfolio includes the Centers for Disease Control, the National Institutes of Health, and the Administration for Strategic Preparedness and Response, ASPR. Her work during her tenure at the White House focused on health equity, maternal and child health, emergency preparedness, social determinants of health, and emerging infectious diseases, including monkeypox, Ebola, and COVID-19. She's the principal author of the White House Action Plan, identifying whole-of-government policy actions to address social determinants of health, with the ultimate goal of improving both health equity and health outcomes. It is my honor to now welcome Dr. Sandra Ford to the stage.
I just need the handheld.
Can we get a handheld mic?
Chair. Awesome. And clicker. Test.
You'll just have one.
I need it.
Do we have a clicker? Could she click through her own slides?
Because they're line by line. We asked about that. Okay, that's not, okay, we'll deal with it. Okay. Good morning. So excited to be here. So St. Thomas was my mom's happy place. She worked for American Airlines for a long time, and so we popped in and out of here quite a bit. So I haven't been here since I was a teenager, but it's really nice. I consider this part of home. So when I told someone I was speaking here about at the Digital Health Summit, the first thing they said back to me is, "You are not a techie. How is this going to work out?" But the truth of the matter is that data is simply information. When you say data, people start freaking out and thinking it's high tech, but it's really just information, and I do love information. So let's go to the next slide. Next, you're gonna, yeah, okay. So the why. Why is this important? And I just want to share a story. So I'm a board certified pediatrician, as was shared. My first job out of residency, I trained in LA at Children's Hospital, and my first job was at a free clinic in East LA. Now I'm bilingual, but not, we don't speak it in my home. And so I spoke so much Spanish at that clinic that people started complimenting me on my English. And I had this little girl, and we kept seeing this child over and over again for the same ear infection. Now, this is a free clinic, so the medication's free, the care is free, but this child keeps coming back with the same infection over and over again. Now, when this happens, you start making judgments, and you're like, okay, is she not understanding me? What is happening here? And so finally, we took the time to actually investigate, and the issue was that they were a family that were living in someone's garage. And so if you know anything about pediatrics, amoxicillin has to be refrigerated to be effective. And so basically this child is taking dead medication over and over again. This was a very humbling experience for a couple of reasons. First of all, let me just say, this was 25 years ago and nothing has changed. That's problem one. Problem two is that if we had not asked the question, we would not have known what to do. Number three, though, is now that we have the information, what can we do? Because that is the issue about data and action, because we have lots of data, but the way we are currently managing it is not allowing us to act. Next slide, please. So we talk about health equity. This definition, next please, came from the Centers for Disease Control and Prevention. And this is our goal. Health equity is achieved when everybody has the opportunity to do their best, their full health potential, live their best life, and nobody's disadvantaged because of their social position, where they work, where they live, or other just socially determined circumstances. So this is what we're trying to get to. Next slide. This is my favorite slide. This is the difference between equality and equity. Now, because and this is important because people confuse these definitions a lot. Equal, okay, I'm 5'2" if I stand perfectly straight. So if you give me a 6-inch box, that's not very helpful because I still can't see. I still can't see the game. Meanwhile, the person who's 6 feet tall has an even better view. And so these are equal, and we say a lot, well, everybody's equal. Equal is same. Equity is fair and appropriate. The second box is equity, which means that me with my 5'2", I get 2 boxes so I can see the game. The person who's a little bit taller just gets 1 box, and maybe that guy on the end doesn't need a box at all. And so that is the difference between equality and equity. Same, fair. Next slide. Now this is my favorite slide because this is what we're really ultimately trying to get to. Right now, there are some people that have a whole lot of boxes and some people that have none. Then we have equality. Everybody gets a box, but the same size. Equity, I get what I need. But ultimately, how about liberation where we don't need any boxes because everybody gets the view, nobody has the fence? So that's what we're ultimately trying to drive to when we talk about health equity. Next slide, please. So defining health equity, we're talking about length of life, quality of life, disease, disability, and death rates. How severe is disease? Access to care. These are the things that we talk about when we think of health equity, but it's so much more. Next slide. Put these on. So I wanted to share a little bit. You know, my whole life of public health, I worked for Republican leaders, and so it's just a little bit different. This is my first Democratic, and without getting terribly political here, it's just the difference for me personally, this is not a political statement, is that I don't have to convince you that something needs to be done. We just need to figure out how to do it. And so that to me was a game changer. So for the Biden-Harris administration, EO 13985, that was day one. That was his first day in office, and the president created an executive order that spoke about equity, and specifically racial equity and support for underserved communities. And he mentioned consistent and systematic, fair, just, and impartial treatment of all individuals. You would think that that's sort of understood, but clearly it was not. And the need to put that down in writing as an edict on day one of office was very powerful. Where I worked, which was the Domestic Policy Council, coordinated equity assessment. So every federal agency was required to do an equity assessment, and Domestic Policy Council was charged with reviewing those and making sure they were appropriate. We also had to create or develop federal resources to advance fairness and opportunity, and you'll hear a little bit more about those later. Equitable delivery of government benefits and equitable opportunities, and then most importantly, the Equitable Data Working Group, which is what we're going to talk about a lot today in terms of interoperability, connectivity, standards. Next slide. Some additional actions, 13995 was on day 2 of office, which talked about pandemic response and recovery. It created the Health Equity Task Force, which I'm sure you may have heard about. Marcela Nunez-Smith created some recommendations around COVID and some of the things we already knew about that were predisposing folks to not make it through that pandemic, and how we were going to address those long term. 14009 was a Medicaid and Medicare ACA strengthening, which talks about that special enrollment period for Marketplace. It allowed for continuous eligibility, which we are about to lose, and we'll talk a little bit about that. Increased access to the Affordable Care Act. Lots of support for HBCUs. As a Howard grad for medical school, I was extremely appreciative of that. Billions. This was the most money we had seen come through the pipe for HBCUs specifically targeted to them. And then the game changer, which was expanded funding for medical residency programs, also postpartum coverage extension. Right now there are only 6 states that do not have the extended coverage, which went from 90 days to a year, which anyone who has a mother who has seen people go through birth understands how life-changing that is to have that support for that extended amount of time. There are some states that have limited coverage, but everybody seems to be moving in that direction. What's interesting is the states that do not have the coverage are probably, they're in the Midwest, which was not necessarily what I was expecting, but hopefully, and sometimes, unfortunately, peer pressure does work, and we'll have to see how that goes, whether they'll move in the direction of everyone else. Next slide. I put this because, we had a lot of conversations during the administration about what was going on with law enforcement across the nation. I don't have to name the names, we all know the names. And so an executive order was put out in May of last year, specifically talking about how are we going to make policing more accountable, how do we enhance public trust and safety of our law enforcement officers. And so these are just some of the initiatives that came out through that executive order. Chokeholds, no-knock entry, we know about that. Also, the use of body cameras required, and limited purchase of military-style equipment, which means silencers. I didn't even know police did silencers. Silencers and high-caliber firearms and ammunition. So these were some of the things that came out as a result of that EO. And we're hoping to continue to see those actions move forward. Next slide. So let's talk about the pandemic, because if we didn't know about health equity before the pandemic, we certainly knew about it after. Coming from, at the time that the emergency was declared, which was in 2020, I had the distinct honor of running both Fulton and DeKalb counties. If you know anything about Atlanta, that's about 25% of the whole state. And so what was stunning to me was, as a person who has a long history in public health, there were folks that acted like social determinants of health was a new thing. And did you know that if you have hypertension and you're food insecure, that you may not have the best likelihood of surviving this pandemic? We already knew that. We knew that people who walk into crises with chronic illnesses and unhoused or food insecure or even victims of domestic violence just tend to not do well when extra crises are added on. Next slide. We saw this very clearly during the pandemic in terms of disparities in death, hospitalization, and infection due to COVID. Now, I want to point out that age-adjusted risk is critical in this because there are different demographics have very different age representations in the United States. The Hispanic Latino population in the US, the median age is 18. The median age for whites is 60. So right there, you have to keep that in mind because they're going to be over and under representation in these different parameters if you don't account for that. If you look at cases, hospitalizations and deaths, it's all there. And you can see there were certain populations that really took a hit, suffered greatly through the pandemic, people of color. So this is what we have, and these numbers are in comparison to white, non-Hispanic persons. And so you see there the dramatic increases that we saw in death and hospitalization related to COVID that were strictly racial based. Next slide. So now we've got the public health emergency ending. March 31st is the day that Medicaid will be shutting down, per se. Well, the continuous enrollment. The actual public health emergency ended on May 11th. It is estimated that between 5 and 15 million people will lose coverage as we unwind this pandemic. Continuous enrollment, as Sissy said, ended on March 31st. Part of that, though, was that Medicaid Part D during the pandemic was allowing a 90-day supply of medicine, which is great, which is awesome. Now we have to go back and do that all over again. So there's a lot of things that will change as a result of the shutdown. Telehealth is going to end at the end of 2024. We're hoping that these things are not locked in stone and can still be negotiated, because as you will learn through the course of this conference, telehealth has been a game changer for folks during the pandemic and should be a game changer as we move out of it. Workforce allowances was a big deal. A lot of folks were teleworking, which allowed them to stay home and care for sick children or children who could not attend school because of the pandemic. That's all done. Everybody's back to work now. And some folks have found that they were actually more efficient working from home. And so what does that look like? And you think about, I don't know about here, but the stress of just getting to work sometimes in Atlanta is enough to, send you off your head before you can even walk in the office. And so there's going to be a big switch as we deal with that. Again, the extended time for meds, COVID tests, treatment, and vaccines are still covered, but only for certain populations. Remember, they were free for everyone. And that continuous enrollment piece is huge, because that means a significant proportion of these United States are not going to have coverage. And of that 5 to 15 million, 6 million are for sure eligible, but just will not re-enroll for whatever reason. Now, each state has their own requirements of how they intend to contact folks to let them know about this re-enrollment period, because people are in crisis mode. And I think that's something coming from the locals that I try to impress upon the administration all the time, because just putting it in a letter or an email does not necessarily mean it gets received. And so part of what I'm working on right now is how do we contact folks that are non-English speaking or don't have broadband, which is still an issue. How are we going to make sure that everyone who is eligible to receive Medicaid benefits in this nation gets them? And so that's something we are very much working on, and is causing me to lose a lot of sleep these days. The other thing that you need to understand that's a positive is that all those COVID treatments and vaccines that were under an emergency use authorization, an EUA, the EUA is still in effect, because that is controlled by the Department of Health and Human Services. So happily, all those treatments and vaccinations are still, at least for the time being, still covered and allowed. Next slide. Okay, so we're back to this again. How do we connect equity to social determinants of health? They're not the same. Sometimes they're interchanged, but that's not really accurate. Next slide, please. Health equity, when you address the social determinants of health, that's how you achieve health equity. You pursue that, and then you're where you need to be. Next slide. So we define the social determinants of health as the conditions in the places where people live, learn, work, and play that impact a number of their health and quality of life risks. Next slide. I've heard it described as social determinants of health, social drivers of health, health-related social needs. Not quite the same, but very, very close. But basically, it consists of the neighborhood, the built environment. Is it safe where you live? Do you have appropriate air flow so that your asthmatic child is not wheezing? Is there no mold in your home? Is it safe? Are you food secure? Do you have options for healthy food and produce in your neighborhood? Are the schools good in your neighborhood? Are they safe? Do they take an interest in the kids and try to put them in a pipeline to college? Or are they just babysitting all day? Do you have social context and relation to the community? This one folks don't think about as much, but we literally saw people die of loneliness during COVID. And so connections and interaction are critical. And as we were on lockdown and our kids were doing virtual school, that was a big issue for lack of connectivity, and a lot of kids experience a lot of mental health issues as a result. Financial stability is a social determinant of health. Are you working? Do you have a livable wage? Because a lot of folks work but are still struggling. Does your income support your lifestyle? And finally, language access is a social determinant in this nation. If you do not speak not only English, but if you are not health literate, because you need to know the right words to say, and we learned that during COVID, because when COVID first came, people had to convince doctors that they were worthy of a test or worthy of hospitalization, so you need to know the correct words. Saying I can't breathe versus I'm short of breath does make a difference sometimes to a doc who's hearing. Next slide. Now, when we think about the social determinants of health, usually it's one person asking another person, do you have stable housing? Do you or your children have enough to eat? Are you safe in your home? So it's looked at as an individual issue, but generally, when there are social determinant issues, it is a community issue. It's never just an individual, it's usually a community level problem. And so when we think about addressing it, even though it will be on some level addressing individuals, because that's usually how we determine, at the higher level, it has to be a community action if you really want to be effective in addressing. Next slide. So let's talk about this. I like this slide because I think doctors think that we're responsible for everything sometimes. And if you see, clinical care is only 10% of health. It's really all of these other things. And so there's genetics. Some people just have bad genetic luck. There's your behaviors. But yes, a lot of the things are social and economic factors. And I've actually seen this pie even more uneven, that even a larger chunk of it was social and economic factors and environmental factors as well. And so we think about doctoring and health disparities, and we are not going to solve the issues in this nation around health equity, health disparities, and the social determinants of health through clinicians, because it takes too long to grow a doctor. I mean, that's a 20-year process. So we're gonna have to figure out some other ways to address these issues. Next slide. These are just a few more measures that have taken place in the White House, more executive orders that spoke to the social determinants of health. We talked about 985, the racial equity. These are just a more data-driven response. They were big on that, mostly pandemic related. 058 was a game changer also, transforming federal customer experience and service delivery. Simply put, that means we just need to make it easier for people to access services. So if you are unhoused, it is highly likely that you are also food insecure. So why do you have to go to two separate agencies, fill out two separate forms, get verified twice? They may be on opposite sides of town, over and over again for every service. Because as was discussed earlier, most people do not have a single issue, they have multiple issues. And so how do we make things easier for them? And some of that had to be, we'll actually talk about a little bit more in detail in a second. Next slide. So let's keep scrolling. So yeah, just make it easier, and that's a simpler way to put it. And so these are just some of the examples of measures that came about through that executive order, simplifying recertification for WIC, SNAP, online WIC purchasing, lots around telehealth, online processes for Social Security, which was a game changer, and online passport renewal without the documents. Those of you who have tried to leave the country understand how complicated that can be, and these are things that have proven to be super helpful, but there's so much more that we could do to facilitate ease of citizens moving through the government. Next slide. These are some funding supports around the social determinants of health. The American Rescue Plan, which was money that came out in 21-22. These are some of the agencies that were funded. You know the White House loves alphabet soup, so let me try to decipher. ESSER is the Elementary and Secondary School Emergency Relief Fund, which provided support for, remember when we were going back to school, all of the partitions and all the extra things that had to be put in place for children to return to school. There was funding to support that. HEERF is the Higher Education Emergency Relief Fund, which did the same thing. CCDBG is the community block grant that provided child care supports for folks who were working. FVPSA is the Family Violence Prevention Services Act. One of the things we saw during the pandemic was that domestic violence shot up because now folks are stuck in the house, and a lot of tempers were flaring and a lot of abuse was taking place, so there was additional support for that. Proud to say this is from the public health perspective. I've never seen this much attention from the federal level placed on public health, and we got a lot of support for COVID testing, for workforce support, community health workers, AmeriCorps, for graduate medical education. But the most important piece for this particular conference is that data modernization, and we'll talk a little bit more about that, but that's very important because right now the public health system it's all over the place in terms of data collection. I'm from Georgia. During the pandemic, there were counties in South Georgia that were doing vaccine documentation on Excel spreadsheets. So, you know, this is why we can't collect good data. Because we just aren't consistent with what we're doing. And then a lot of help from the administration for mental health and substance use disorders, which has continued and will continue to be a problem in the United States. Next slide. So the White House Conference on Hunger, Nutrition, and Health took place in September of last year. This is the first White House conference on hunger since in 50 plus years. That's important because the last conference that came about is how we got WIC and school lunches. So there was a lot of pressure to come up with something big like they did back then. And so the goal was to increase, well, first of all, to end hunger by 2030. Now that's a goal. Increase healthy eating and physical activities by that same amount of time. And it focused on food insecurity and diet-related diseases, brought in a little bit of everyone, the business community, philanthropy, academia, tribal and territorial governments, local and state, ag was there. And so they had these pillars, and the one pillar was to improve access and affordability. So we're talking about groceries and even how things are presented in grocery stores. If you notice, they used to have all the sweet stuff in the front and all the junk food. Most of the time now when you walk in, you tend to see produce before you see junk. Integrate nutrition and health. We still sometimes don't understand that link between what goes in your body and how your body operates. How do we empower consumers to make the right choices? Sometimes, I mean, we still have folks that go for the dollar meal because it's a dollar meal. And so how do we help make better choices and facilitate that? Supporting physical activity for all. When I was in school, you had to have PE to get a diploma. Now, you maybe not. I've seen PE online. I don't even know what that means. But this is because we're so focused on numbers and scores that we don't necessarily graduate healthy kids. And then, of course, nutrition and food security research. You know, I come from a multicultural background, and that's why I love the Caribbean, because most people come from multicultural background here. Food for us is very little about nutrition. It's about love, it's about comfort. You know, I had a great day, have a piece of pie. I had a terrible day, have a piece of pie. And so we need to be respectful of culture as we talk about nutrition, because you cannot just destroy history by trying to be healthy. And so we need to do research and understand how culture plays a role in nutrition, and how do we communicate important messaging without condemning the way food is prepared. And so there's a lot that needs to be understood on that. And for a lot of cultures, they cook the way they cook because that's all they could cook. And so we need to understand that as well. Next slide. So I'd like to now talk about my baby, which is the White House Action Plan on the Social Determinants of Health. This was a 14, 15-month effort that pulled together 30 some odd different agencies to talk about the social determinants. My goal, coming from local public health, was to figure out a way to link the hospital system, public health, and the social services system in a way that was seamless, and to come up with some policy levers to make this easier. And there were 3 pillars: blending and braiding of funding, which is, anyone who has ever written a grant understands that is a game changer. There are so many inflexibilities in the way grants are written that it sometimes prohibits the same action that is expected. I'll give you a perfect example. During the pandemic, both Fulton and DeKalb counties had EHE funding, which is End the Epidemic for HIV. We got a whole lot of money, which was lovely, but part of the requirement was community engagement. Okay, well, we're in the middle of a pandemic, so that in and of itself is a challenge. But more importantly, P.S., you can't use the money to feed people. But I need you to meet them. Who meets? You meet after work. You meet after work at 6 o'clock. I have to feed you, or you're not going to come, or I need to find something to do with your children. And so none of that is generally covered in these funds. And so, you have the money, then you have to find an outside source to pay for your food so that you can meet with people. And so if we just had more flexible funding, or the ability to blend and braid, which means just marrying funds together without a whole lot of complicated reporting structures, it would be super helpful. The second pillar was support for backbone organizations. And a backbone can be a health department, it could be a community-based organization, but what we find with grant writing sometimes is you cannot pre-select an organization. And so what happens is you get your notice of award, and now you've got to scramble to try to pull together a community-based organization who may not have resources. And so they're living grant to grant. We need to find a way to support that, make them sustainable in between funding so that they continue to operate. And some of these funding flexibility should include support for them. The most important part for this conference is the alignment of data use and privacy policies, and that includes the data interoperability, the data interconnectivity, the data standards, because right now what we learned during this process was that everybody agreed that they were doing work on social determinants of health, but it was in no way connected. And we were all serving this most likely the same populations, but nobody knew who needed what or how to link them. So those were the 3 big pillars that came out through the action plan, which is completed. It was in draft. It's been submitted at the end of December, still waiting for all the clearances and approval, but very excited about this because coming from the local level, this was desperately needed, was just help us understand some policies. More importantly, give us some guidance. Let us know what is allowed and what is not allowed, particularly related to funding and data sharing. While no one was comfortable creating specific guidelines for whatever reason, what we did do was pull together from the state and local levels best practices. There were so many amazing projects already taking place at the local level that simply needed to be magnified. We already know all the excellence is down here. How do we magnify it? How do we replicate? How do we expand? How do we support? And so I think even having that information of, well, okay, North Carolina is doing this or Washington is doing that, this is how they pulled it together, would be super helpful. Next slide. So, why is this important? Now, my dad is from Barbados, and he always says, knowledge is power. You cannot fix what you do not know. And so I'll go back to my original example of the little girl. I can't fix it if I don't know. And so we would have been chasing that ear infection literally for years. She may have even had hearing damage by the time someone figured out the right question to ask. So that's number one, is that we need to know what we're working with. Number two, resources are limited. And so you have to provide a compelling argument. And as the governor said, most legislators are, oh, tell me what can get me elected. Social determinants work, public health work is not sexy because it is not, you cannot put money at it and it gets better overnight. And so most legislators are interested in things that they can say, I did this and 6 months later that happened. So, social work, public health work, it takes a long time to manifest, but when it does, it's powerful. What we talk about also, because we know that resources are limited, I look at it almost like chemotherapy. When chemo first came out, we just gave it to people and it just killed everything, you know, which if you're trying to live, okay, that's fine. But now we have tailored chemo, which really only targets the cells that are offending. And so knowing that resources are limited, we need to target the intervention. So let's find out where that community is that is having all of these issues with housing or with food insecurity, and we target our interventions accordingly because we don't have enough money to give everybody the same thing. So that's back to equity also, is that we give what is needed for that time and for that person. Then we need to talk about ROI, because this is also part of the challenge with social determinants and health equity work, is that people can't see the financial gain in it. And so we spend a lot of time with our health economists trying to help people understand that if you give someone a home, then maybe they won't pop up in your emergency room every 4 days with an open wound from their diabetic ulcer. Or if you give them a reasonable amount of nutrition, then maybe their pregnancy will make it to term and they'll have a nice healthy baby instead of a preterm malnourished child who then is at risk for abuse and neglect. So we need to be more thoughtful about how we talk about ROI. And there's still, there's the social ROI is still a thing, because there is simply just the greater good that you do it because it's the right thing to do. Sometimes that's a tougher argument, but it's still an argument nevertheless. And for some folks, and a lot of these big corporations do have a social justice piece. And so we target them and say, hey, listen, if you're really looking to do some social justice, here's some things we can help you spend your money on. So social ROI is one piece of it, but the fiscal piece of it, and we have shown that if you invest in these social determinant interventions, you will see decreases in hospitalizations. You will certainly see decreases in bounce back, and you may see some other things correct themselves as well. But again, we have to have the data to quantify that and to really measure it. And so it's really hard sometimes to collect that, because there are so many other factors that contribute to well-being globally that it's hard to say, well, because I gave that person a house, then this is why they didn't show up in the emergency room. But we've got to figure out a way to quantify them. That's why data is so important. And then outcomes and evaluations. Now all of your grants require you to do some sort of outcome evaluation. How did this work? And not just widgets. We saw 8 people and we gave them 8 blood pressure cuffs. No, but did they show up in the emergency room? Did they have to have their medications increased or decreased? So it's a lot more detailed than just how many, which is how we used to do grants. Now it's, but what? And so the data piece of this, the data collection, is so important, because we need to know whether the interventions that we think are working are actually working. Next slide. So what data is important? And we talked about this a little bit this morning as well. Race and ethnicity data. Race and ethnicity data was not being consistently collected through probably the first 3 to 5 months of the pandemic. So we really didn't know who had what and who was dying from what. Some folks were collecting it very well, and some folks weren't even bothering to ask. And so that's the thing. SOGI is social orientation and gender identity. Why is this important? Because we want to know Do you need protection? Are you safe? Because we still have a lot of issues with transgender and folks who identify differently from whatever we consider normal. And so that's important because we need to make sure that you are protected. Income data obviously is important because we need to know who's struggling, who's not. What are your social needs? And that's broad. Is it safe? Medical history, and this is one for whatever reason that people are uncomfortable about sharing, but your medical history is definitely related to your social needs in many instances. And if you are asthmatic, then one of your social needs may be a house that is free from mold or pets. The et cetera is everything from your marital status to your disabilities. Are you wheelchair bound? Are you hearing impaired? Do you not speak English as a first language? These are things that are important. Are you in a safe environment? Those types of things. And so these are some of the data that we need to be consistently collecting across the board, because some of these things are collected all the time and some of them are never collected. And so if we're really trying to address social needs, health equity, there has to be some sort of consistent collection of data, which is a data standard, that we need to all be doing and can all access. Next slide. So what are the barriers to collecting good data? I have heard people invoke HIPAA for everything. HIPAA is not be all and end all. Anytime you talk, oh no, that's HIPAA. No, it is not. It's a very specific category of information that is HIPAA, and everything else is open. And even HIPAA has some flexibilities. And so, we need to just leave HIPAA alone and let HIPAA be HIPAA and collect all the other data that we are allowed to collect. Now, this second one, I don't want folks in my business. This is the thing. Actually, when I was looking up Virgin Islands and just trying to get a sense of your medical history, some time ago there was a survey done here of your consumers, and one of the main things that they said, they were mistrustful of the health community, and they were nervous about sharing their information, and because it is a small island, and so unlike Atlanta, there's much more of a risk that your doctor knows your mom, or is your neighbor, or shops in the same grocery store. And so confidentiality is a big issue, and that's the same everywhere. People just have a mistrust now of sharing information, which is ironic to me, because if you have a cell phone, they have all your stuff anyway. As you can tell by the ads that pop up, if you say something, then it shows up on your phone. And so there's a lot more access to people's personal information than I think they're aware of, but there's still that fear of sharing. Also, if you are undocumented, if you have a substance use problem, if you're a victim of domestic violence, people are just afraid to share information. The other barriers outside of just the personal field is agencies are so siloed. What we learned during the creation of the Social Determinants Action Plan was that everybody had a data system, but nobody's data system communicated with anyone else's. And so that is just a huge frustration, and we've been trying to figure out some sort of common platform that allows folks to exchange data across agencies, across systems, and that's the ultimate goal. When I was at the state, they wanted to have, we have 18 different public health districts in Georgia, and each one has its own IT system. And so there was this edict that you all must have the same IT system across the entire state. Now, that's a financial issue, so it's easier said than done. But more importantly, my argument was, okay, I have an Android, but if I say, does anybody have an Android charger? You're going to raise your hand, and we may not have the same Android, but we just need the same charger. And so it's not so much having the exact same system, it's just having the connectivity. So any Android charger works on any Android phone. And so we should be able to have a system where I plug in my adapter and I get the information I need from your system without disrupting, because if I use your charger, it doesn't mean you can't use your charger anymore. It just means now I've got the ability to gain my information. So we just need to figure out a way to have these siloed systems communicate with each other. The challenge, though, is this lack of technological expertise. And I say that in all honesty. Part of the problem is that I don't believe that there are a lot of public health, for sure, public health IT people who know how to do this stuff. As evidenced by the fact that we had a system that had Excel spreadsheets in it. Building a system that captures the appropriate data is a challenge, and then allowing it to communicate with other systems is an even greater challenge. And so having that technological expertise that knows how to do that and knows how to train folks who are going to be using those systems every day is a big challenge. And then, of course, that's a financial constraint because new systems cost a lot of money, and then if you pile on training and TA for that, that's a big deal. Next slide. So how do we fix it? Trust. And that sounds trite, but it's not. We have to have our patients trust their providers. We have to have our agencies trust each other and be confident that the data that is shared is as protected in my agency as it is protected in yours. We have to trust that it will be used for good. Policy, we can say a lot, but unless it's in writing, it doesn't happen. So we need to write down rules, federal, state, and local support for data sharing, for data interoperability, for data standards. It needs to come from above and from up. A common data platform would be awesome, cloud-based, so everybody could access it. Funding that supports those IT upgrades and technical assistance. You saw some of that with that data modernization funding. That was $3 million. That's probably all gone already. We need much more long-term support for IT upgrades, for technical assistance, so that we can train people to do the work that we need to have them done. Cybersecurity has to be protected. I know several health departments in Georgia that got hacked and were ransomed, and they paid because you've got to be up and running. And this is an issue nationwide where something gets hacked and then we can't operate. Revising those grant deliverables, and grant reform is definitely one of the pieces that we had put in the action plan, and that was some ongoing work that is encouraging, but again, takes time. Flexibilities around funding, how funding is used. Indirect costs were a big issue for a lot of grant recipients. I also heard match. If you're a small county and you've got money, but now I've got to come up with a fraction of the funding to even start the work, that's an issue. I don't know where match came from, but it's a killer for small communities. And so if we're going to talk about grant reform, the requirement of match needs to be addressed. The flexibilities of indirect funding, because it's never enough to cover what is actually needed in terms of support staff. So these are some of the things that we're working on that at least they're aware of. I feel like, again, knowledge is power. So if it's on the radar, if I told you, then it's up to you to figure out, the next steps or how to fix it. But we tried to make them aware that this was an ongoing problem and a challenge, because I had heard stories of people turning down funding because they just didn't want to be bothered with all of the paperwork. And meanwhile, we say, oh, well, we've got all this money, but nobody wants it. Well, if I have to come up with $30,000 to get $100,000, well, if I had $30,000, I probably wouldn't need the 100 in the first place. So we've got to have more flexibility around how we distribute our monies, and reporting structures was also the other thing I heard, was that this is a big challenge. We're not asking the right questions again. We're counting widgets. How many people did you see? How many people came to your health fair? Okay, but are your health outcomes any better? Are we really, and that's again, data collection. Are we seeing what we're supposed to be seeing? Because we can check off boxes and say, oh, well, I gave, 100 people a blood pressure cuff, but did they not bounce back? That's what we're trying to figure out, is what are the wins for this? And numbers is not the win. Outcomes are the win. And then finally, if we do this correctly, next, we see improved linkages. Just one at a time, please. We see better connections of folks. we see a better connection of the healthcare system, of public health, and of social services. We see better linkages between agencies. Right now, we have some fledgling partnerships that are very promising, but we are actually, there is a Social Determinants Accelerator Act currently sitting somewhere out there in the stratosphere that I'm hoping they will codify the structure that we put in place in the White House to develop the Social Determinants Action Plan, which is a required gathering of these agencies periodically to sit down together and figure out how to collaborate, how to address these issues. And again, it's so sad to me that you would have to put that in law, but if that's what works, then that's what we need to see. So linkages, when we get it right, they're better. Service delivery is seamless. My goal would be to see the one-stop shop where you walk in, I've got your QR code or whatever it is, and on that QR code is everything I need to know to help you. So this is Mrs. Gonzalez. She has, she's living in an apartment that's not safe, or her grandson is a substance user. How do we support her? And then there's dignity, because now I don't have to ask you the same questions over again because I already have them. And so you're able to deliver the care in a more respectful way and more purposefully. Next. If this works, we are more efficient, because right now we waste a lot of time collecting the same data over and over and over again because we just don't have a way of sharing the information. So if I go to WIC, I give them the information. Then I go to HUD, I give them the information. So, or talk to my case manager. That's a whole nother set of the same information. When I'm trying to make an appointment, it's so annoying because the person that connected me already asked for all the insurance information, and then they get on the phone and they're like, I'm like, I just gave it to her. If we could just do that, and that's just a small example, but to try to do that on a large scale, if you're already frustrated, you may hang up the phone and then you just don't get your services. Targeted interventions, when we get it right, we direct the money where it is most needed. We point to the folks, the communities that are suffering, and you direct your resources appropriately. Again, back to equity. Who needs what, when, and how? Next. You have the approved ability to advocate, because without the data, I can't, in my state level positions, I've got a legislator in the elevator. I have like 30 seconds to get his attention. Or when we did Hill visits, you're sitting with a whole bunch of other folks who also have issues, and you've got not even the legislator, generally a staffer who's probably, you're number 43 of 60, and so they're like, wrap it up. So my job is to tell you a story that is so compelling that you want to help. And so for me, a win, if I start with data and I say, did you know? And they say, tell me more. That's it. That's all I need, because once I tell you more, I've got you. And so good data allows you to store what I call killer facts and just throw them at them, and that may be the difference. Just talking about that difference in the median age of the different ethnicities. For a lot of folks didn't know that, and so they're like, wait, what? Because that means a lot in terms of voters and in terms of funding. So the ability to advocate is enhanced dramatically when you have the right data that you can pop out quickly, that's easy to understand, and is powerful. Next. When we get it right, we save money, ideally, because then we're keeping people out of the emergency room. We're creating other services that keep them well physically, well mentally. We are focused on ensuring that their overall well-being is improved, and that saves money. If you keep people out of the hospital, you keep people out of jail, you keep people out of juvenile detention centers, and all of these things are connected, because behavioral health is a huge part of why we see what we see in terms of crime and violence. You save money. Maybe not in 6 months, but maybe not in 3 years. But if you do this correctly, over time you will see a savings. You will see a cost benefit of these types of interventions. We will get better data because we will all be collecting it the same, and we will be collecting the same data, and we will be sharing data. And so that is a win. When we get it right, then we have good data. We have better journal articles that won't be challenged all the time. We have, better support for funding because everybody gets what we're trying to do. And most importantly, we have better outcomes. Next slide. This has been an honor. I hope that you got something out of it. I hope that you feel the passion that I feel when I talk about this. As a doctor, recognizing that it was not about us. It's about all the things that help us do our job, which is having a child come in with a full belly, with a good roof over their head, in a safe environment, with caregivers who are mentally there and nurturing. That's the difference, and that's how we grow healthy kids, and that's how we grow healthy communities. Thank you so much.
Thank you, Dr. Ford, for that excellent presentation. I hope you guys take advantage of lunch times and any breaks later on to really dive deeper, because you've heard a lot, but it's a little compared to what is clear is Dr. Ford's knowledge and experience base. So we're going to have to be flexible today in many ways, I'm sure, like many of you have been with the shuttle service. We're going to be flexible, and we've already got some presenters who are going to swap their sessions. We were going to have an all virtual panel. They need to change that time. So we're going to be bringing up our give me 1 second. I've got too much going on up here. We're going to be talking where this actually fits nicely. We're going to go beyond clinical data and hear from the folks we've just heard that we need social determinants of health information to inform the whole picture of the populations we're serving. We're better able to make informed decisions with more information. But now we're going to hear from a group of people who's actually doing that and how they're doing that and of the variety of ways they're doing that. So I'd like to welcome to the stage, this is kind of a large panel, so feel free to grab a beverage or a snack as we bring up the folks for beyond clinical data. I'm asking Damon Hausk, Dr. Christine McCoy, Dr. Maria Wanda to come to the stage, please. We'll call you all back in about 5 minutes as we get them set up on stage. Welcome back. We're welcoming you all back in here. So again, we just had a fantastic master class again from Dr. Sandra Ford. And it sets up the next panel perfectly. We've got Dr. Maria Wanda from Howard University, Dr. Christine McCoy, Damon House, Michelle Zankin from ZaneNet. We've got Boyd Mark from the Southeastern Regional Telehealth Center, and Dr. Ekpo from Department of Health. So our three presenters are going to share specifically about what the work that they're doing that bridges the silos we talked about, that bridges the data gaps that prevent us from being able to provide the kind of health care that we know we want and need. And then they're going to have a chance to ask the folks on the left about some of the work that they're also doing and some of the resources they have available that you'll want to hear about. So it is my honor to welcome all of you. They're going to share a little bit about their bios, or I'd stand here for the next 10 minutes reading bios as they present. So thank you all for participating. Dr. McCoy, please take it away.
Aloha, everyone. Good morning. So nice to be here. And let me just start by sharing a little bit about myself, if we want to bring up the next slide. Oh, sorry, actually, let me just say, first of all, that welcome to the lightning round. As you can see, there are 6 of us up here, so we've got a lot to say and not very much time. Luckily, at least in my case, everything I needed to say has already been said by the earlier presenters today, so that's going to make my job a whole heck of a lot easier. So next slide. I wanted to talk to you all this morning about, again, we're bridging the gaps. I'm talking about digitizing whole person care. So there's a little bit of background about myself here on the slide, and I really wanted to highlight just a couple of things. I greeted all of you with aloha because my island home, not currently, but previous to my current home, was on the big island of Hawaii. And the reason I was brought to the Big Island was to develop a training program for primary care dream teams. And what I mean by that is when you're on an island like this one, the Big Island of Hawaii has 200,000 people. You're very isolated. You don't have a lot of access to tertiary care without getting on an airplane. In fact, we had a full-time, essentially, travel agent in our office just to get people to where they needed to go to get care. And so you really have to be good at what you do. You have to be better than good at what you do. And I had come from caring for the agricultural workers of California's wine country to caring for the people of northern New Mexico in the villages that have been there for 400 years, a combination of indigenous people, Spanish people, and a lot of hippies, and then moving to the Big Island of Hawaii with, again, a very multicultural group of people, a lot of poverty, just like here, and really trying to figure out how we could do the absolute best care for people. And again, it's not just about medical care, it's about understanding that entire context of people's lives. And luckily, as you can see, I didn't start in medicine, I started in public health. My grounding was in what was then Healthy People 2000. It was in understanding really what was going on with people and trying to get to the actual causes of death and what was behind those actual causes of death. And so it wasn't a heart attack, it was smoking. Well, why are people smoking? Et cetera, really trying to understand where all of that was coming from. All right, next slide. This is just my current, I'm not currently with Stanford Health, that was on the slide, not quite right, I am Stanford educated, but I am currently consulting for Two Oceans and also with the Stewards of Change Institute, and I'll talk more about that in a little bit, and advising a tech startup company that is not here today. Next slide. All right, I wanted to talk a little bit today about 2 very particular things, and again, very briefly. The first thing that I wanted to talk about is an initiative that came out of CMS, and specifically out of the Centers for Medicare and Medicaid Innovation, called Integrated Care for Kids. And I want to talk about how this is a brilliantly conceived initiative and an initiative that needs a whole lot of help if it's actually ever going to come to fruition, what that vision was that was put on paper. And the second thing I want to talk about is consent to share personal information. We heard a lot from the earlier presenters about how we don't necessarily want to have other people in our business. As I said, I worked in rural areas where your like sister-in-law, who you don't get along with so well, is the person working at the welfare office. So you have to be really, really careful about who has your information, because there are consequences to it being shared. On the other hand, most of us, again, we don't want to fill out that same information over and over again, even if it's boring information. And we sure as heck don't want to tell our traumatizing stories over and over again. We have an expectation that the people who are caring for us can be coordinated and can work together and can understand what is going on with us and can wrap that all up in a big picture. And that's everything as simple as not giving a temperature sensitive medication to somebody who doesn't have a refrigerator to keep that in all day. And, you know, oftentimes I talk to my fellow family physicians and they're like, why do we have to like talk about the social determinants of health? And I said, do you realize when you give somebody, whether it's a child's antibiotic or insulin for an older person, and they don't have a place to store this, or they can't keep needles in the homeless shelter where they stay because needles are not allowed in that homeless shelter, that they are therefore not taking that insulin that you gave them. These are really, really important things, but they're things that don't occur to a lot of practicing clinicians, unfortunately. All right, so let's talk a little bit about integrated care for kids, otherwise known as INC. If we can go to the next slide. I just wanted to give you a sense of you know, where this is happening and really what this amazing vision was of this initiative. So awards, there were actually 8 awards given, and because of the challenges of carrying this out, one of the awardees, the state of Oregon, pulled out of this initiative because they said, we can actually do this better on our own without all of the constraints that Dr. Ford was talking about that we get when we get grants. Sometimes those constraints are so bad that you just have to walk away from the funding source. And that was the case of Oregon when it comes to INC. But on the other hand, INC was really, really, I think, well conceived, as I said earlier. This is what they said. These are the core child services. Now, this is a program coming out of CMS, but this was not about medical care as it was conceived. This is a program that is talking about everything that a child and a family need in order to thrive and do well and have that child be, you know, well developed, well educated, and come out ready, you know, to be a productive citizen, as we like to say. And it was, again, absolutely amazingly conceived. And since this is a technology conference, what was even better is they wrote interoperability into the NOFO for this program. And they said, we want you to achieve this by using interoperability. Unfortunately, none of the background work was done to make any of that possible. So Michelle and I were at the APHSA technology conference last fall. It turns out folks in the Human Services side have never heard of any of the data standards that we talk about. USCDI was talked about earlier this morning. They don't know what USCDI is. They don't know what, you know, FHIR or any of the things that we do in healthcare IT are. And we need to change that, because the only way that we're actually going to be able to have this connectivity among all of these systems so that childcare can be connected to child welfare, can be connected to education, can be connected to healthcare, as in this vision with INC, is if we at least use USCDI across the board. We have to be able to know that Johnny Perez is John Perez, is, you know, J.A. Perez, that those are all the same person. We've got to be able to match their demographics, and that we have to decide some of these core issues that we know are important to talk about, say, Johnny's housing status. Johnny's parent or guardian status, all of those things, they need to be captured as data that is understandable by multiple systems and be able to move those across throughout into these other systems so that we can work together to care for Johnny. So this is the vision. We're definitely not there yet, but I really thank whoever put this together for CMMI for conceiving of it, putting it out there on paper, and all of my my fellow colleagues around the country who are working to try to chip away at this piece by piece by piece. And you know, the good news is with the 7 projects that are ongoing, there's small victories happening in each one of these projects, and really part of what we need to achieve is to learn from each one of those and to pull that together and to go back to all of our federal agencies, state agencies, and county agencies, hopefully after Dr. Ford's action plan has come out of mothballs and gotten out there, so that we have that behind us to really help to back up what needs to be done to make this vision of integrated care for children a reality. The other piece I want to talk about, we can go to the next slide, is about consent. Yes, and I'm not wearing my glasses, sorry, so I can't see. They're too dirty and these lights are too bright. But so all of you technologists here can build the best system in the world that does amazing interoperability, but if the lawyers and the people who are scared of lawyers have not been tamed in this process, we won't be able to use all of these amazing systems that you build. Now, one way to move us not around that, but towards that, is to also develop technology systems where we get people's consent. So that if you don't want people in your business, you don't have to have people in your business. You will personally tell and provide the information to every organization, system, community-based organization that you need to. On the other hand, if you would like that all taken care of for you and you want to know what programs you're eligible for and have that important information shared for your care coordination, you ought to be able to select and make that a reality. And so this is the other work that I'm doing right now. And it's complicated, as you see here. There are a lot of different elements that you need to have in place to be able to build a truly efficient consenting system. So that you can make the consent executable and computable electronically in an ideal world so that this can happen and the electronic gates can open and close as is appropriate to move information amongst systems. Next slide. So, you know, just very briefly, and actually I'm really grateful to Dr. Ford for bringing up HIPAA. This is very oversimplified, but at a minimum, we have to figure out how to move. We talk about HIPAA covered entities all the time and how we can share information because of HIPAA, but we have all this other stuff. And not only do we have our HIPAA business associates, but this should probably be a much bigger green wedge of the pie. We have a lot of HIPAA non-covered entities, as well as we have specially protected health information as well, too. And all of those have to be dealt with in a different fashion. Next slide. And so I just wanted to talk about what the preconditions are to be able to give informed consent to share. And so we have to, being informed is really the most important. We can't put agreements in front of people that they can't understand. They have to be in third grade language. They need to be in their language. They need to be vetted by people in various communities to understand that people really know what it is that they're signing up for to have their information shared. And we know from the experiments that have been done all around the country that the vast majority of people will choose to do that when they are given that choice. But it is really, really important for equity to be able to give people that choice and have them understand that this is something that is done on their behalf when they want it to be done. And then trust. Trust was brought up before. So we have to work on building trust. We have to build trust between government agencies, which was something that Dr. Ford talked about, and we have to build trust within our communities and at every level in between in order to implement this. And one of the things I heard about here on the Virgin Islands is we have to build the trust of the unions. So the unions are, very protective of their jobs, and they need to understand that they can do their job better if they're working together with their fellows in other unions or in other jobs within the union. And I think that's one of the ones that we really need to work on. And then finally, again, we have to make sure that we are compliant with the laws, policies, and regulations, or that we change those laws, policies, and regulations so that they work to actually serve us as a community. So with that, I'm going to turn it over to my colleague, Mary.
Thank you. Thank you, everyone. I'm Mary Awanda, and I'm so pleased to be here. My son thinks his mom is a superhero. She made it to the Virgin Islands. So this morning, I thank the ancestors for bringing me here, and I believe I'm probably the first of my ethnic group to be here. And so I'm so privileged to be here. I'm from Howard University College of Pharmacy. I'm a pharmacoepidemiologist and health services researcher by training, which is just a fancy word for, we've been doing statistical analysis and reporting on patient-reported outcomes. But my most recent passion projects have been in workforce diversification, specifically healthcare workforce diversification, and also in telepharmacy. And so I was fortunate to be among the many colleagues and I would say friends at this point who launched the first telepharmacy and population health center at Howard University. So I'm glad to be here. And next slide, please. So I'm here to talk about, actually, I think this is the wrong deck. But I'm just going to keep talking while the technology, works its way through. But essentially, our telepharmacy center was designed to do three things. And if there's three things I'm absolutely passionate about in terms of the conversation of telepharmacy bridging gaps in care, is that one, telepharmacy has to be done right. In other words, for digital transformation to actually have an impact, it has to be able to be in service of our most vulnerable. And so yes, it's going to take a lot more time, but I think we wouldn't want digital transformation to be the conduit of expanding and increasing more healthcare disparities. So I think that's the first thing that we wanted to make sure in building our telepharmacy program, was that it was built to make sure that it actually did a service to making sure that our patients were empowered, one, to understand how the care event is going to take place, and two, that we're true partners in engagement in this process. So that's the first thing. We have to do it right. The second thing is, I'm a strong believer in pharmacists being able to contribute as agents of digital health transformation. I think pharmacy has come a long way from just doing dispensing functions. Pharmacists are now able to be more patient-facing and do a lot of the things that aren't able to be done during the course of the main encounter with the physicians. And so this is where telepharmacy can play an incredible role in terms of making sure that patients have the right medications, that patients aren't experiencing adverse events, that the medication they took 10 years ago isn't still showing up on the electronic health record, and others are making decisions on bad data because information hasn't been cleaned out. So that's the second thing. And then the third thing I'm a firm believer in is making sure that we are training people the right way to be able to function in this new environment that is requiring everyone to have different skill sets in terms of expanding, access to digital health tools like remote patient monitoring, analytics and population health. And that takes time, and that takes, a passion to wanting to transform learning, particularly at the level of professional education in pharmacy and other healthcare professions. So I'm a strong believer in making sure that we are training people in a way that is going to bring change and is going to be impactful. So those are the three things that I'm passionate about, and our center is supported very much by our friends, and it's a special shout out to Zaynet, and a special shout out to SNC Telehealth Solution, who over the pandemic really helped us realize our vision. And it's funny how things come to play. We really didn't set out to have this huge telepharmacy program. I really just set out to help my students, because my students couldn't be on site. If you remember during the pandemic, healthcare students couldn't go to clinical sites to be able to receive training. And so one of the things that we decided to do with some of the CARES Act funding that we got was to set up telepharmacy for just training. So clinical sites didn't want our students over, that we could be able to help them participate through our telepharmacy platform. And so what started off as a desire to help our students has transformed now into a program that has our clinical operations and has our training operations. So we're really, really grateful. The other important point I wanted to bring up was sort of the divide in DC, which is sort of the population that we serve, and that DC is divided up into 8 wards, but the healthcare outcomes in Ward 7 and 8, which is frequently referred to as Southeast DC, are absolutely concerning, and things were worse over the pandemic. 70% of the people who died from COVID-19 were from 2 wards. So that speaks to the intentionality that we have to have and the urgency that we have to have now to make sure that our digital transformation truly meets people where they are. And so we will talk about one of the things that I'm extremely also passionate about is putting telepharmacy in spaces that are not traditionally spaces where healthcare takes place. One of the most successful things that happened over the pandemic is, people were able to get vaccinated in places that you traditionally weren't going to get vaccinated in churches, in restaurants, in different places. So healthcare was truly in the community, right? Truly in the community. And, as things dial back, my fear is that now people are going to have to go back to, our old habits of seeking care in spaces that are traditional, which is part of the problem. And so if we want to talk about bridging gaps in care, we want to have to think about how is healthcare going to be delivered in non-traditional spaces. So my hope is that we're going to be able to take our telepharmacy program to senior wellness centers, to family success centers, to spaces where people traditionally live, work, pray, and live, so that way they can access their care there. I'll end with sort of an African proverb in terms of how things have worked out for me personally, in terms of if you want to travel fast, you go alone, but if you want to travel far, you go together. And so I think part of our charge at the summit is how we're going to travel together to make sure that we achieve success and for our patients. So thank you. I'll turn over the mic to Damon.
So good morning, and for those of you who may be online, good afternoon, good evening. My name is Damon House. When I met Michelle last year, I was employed by Microsoft, and I was in charge of solutions and strategy for healthcare and for education in our worldwide global services division. My passion was helping under and unserved and underrepresented communities, communities of color, rural communities, veteran communities, bringing healthcare and other industry services to them, and thinking about digital transformation and how it could change their outcomes. When we had the summit last year, and I said, "Ooh, Microsoft, can I come down?" And they said, "No, you don't need to go down." And that was when I started thinking that maybe being there, while it afforded me a lot of resources, was constraining me in some of the things that I could be doing for our communities. And so I am now on my own. Michelle tracked me down and she said, "Can you come down and talk about digital transformation?" And I said, "Well, I used to eat and live that every day. I would love to talk about that." And so that's some of what I want to talk about today. Although I'm sorry, you're going to have to hear me run my mouth tomorrow about AI and kind of demystifying some of that as well. But if we can go next slide. When I think about digital transformation, I want to lift it up a level and start thinking about it from an industry perspective. Does this make me sound better? See, it doesn't. Not just me. So when we look at this slide, we understand the quadruple aim of health. And if you don't, I really suggest YouTube or Google. But one of the things that I started looking at for the digital transformation of health was also health equity. And we have spoken about that. So I'm not going to belabor that point. But if we can go to the next slide, one of the things I really want to point out is data is here. We're collecting data in hospitals, but we're also collecting data in the home. And that digital age is here, and we need to make sure that we are leveraging all of the data that we can for that whole person, that whole patient experience, and bringing all of that in. So if we go to the next slide, what I started thinking about was the patient experience. So if we look at this map right here, and we start on the left, we want to keep people healthy for as long as possible. It makes sense, but we're human beings, and we are built, unfortunately, to break down. We get sick. And so as we go through this map, from left to right, we have the person getting sick, being diagnosed, or identifying that they believe that they are sick, and being diagnosed, being treated, being streeted, or put back out onto the street and sent home, where we hope that we can manage their wellness for as long as possible and keep that cycle going. And so when I look at this type of map, I say there are a lot of opportunities where we can have those points of engagement. We've spoken very eloquently about those. If we go to the next slide, however, what we start to see is sort of the breakdown of what this could look like in an industry level. So on the left, you see operations. That's a hospital. That's a provider. They think about staffing. They think about budgets and analysis and inventory and those types of functions, including smart buildings. And on the left, we see the clinical engagement. We see telehealth and bots and virtual care. We see remote patient monitoring. But those two data sets need to come together for a provider and for an organization to have a better understanding of how to treat a patient. If we don't have the right clinical staff, inventory, what we need to treat a patient, it doesn't matter what they present with when they come in. So we have to think about that holistic overall care and then take the insights that we can do across those two to have better visualization, better reporting. Now, next slide. The next point is, well, wait, where are the patients? Well, if you look at the upper left, how can we have better patient engagement? How can we take that data and make sure that they are a part of their care decisions? So it's not necessarily just about population health and public health, but how can we make sure that they are informed and empowered to drive their own care intelligently and articulately? And now for the eye test, next slide. We really started looking at the ecosystem. And when we look at this, we start looking at what are partners, what are tie-ins to other industries like telecommunications, like agriculture. On the left, how are we looking at lifestyle management? How are we encouraging them to be healthy, to walk, to eat better? And this gets to the social determinants of health. This gets to some of the things that we spoke about earlier today, where we inform them that you're in a food desert. We want you to eat better so that we can prevent some of those issues from arising. Now, I'm zipping through this, and I hope that the presentation is made available because I also want to make sure that we leave time for everybody else. But on the next slide, right now we know that data in leads to bad systems. Good data, good systems. And so when we look at insights and care coordination and virtual health, the things that I look at are operational engagement, clinical enablement, and then patient empowerment. And if we can keep that at the core of what we're doing, and I will bring in the social determinants of health more deeply tomorrow, but we can keep that at the core of how we engage clinically with efficacy and compassion. I think that we can have a better solution in driving healthcare outcomes. Next slide. One of the things that we started looking at is how can we have a North Star? How can we say, not where do we want to be tomorrow, but how do we be there tomorrow in 7 or 10 years? And Dr. Ford talked about this when she said that there are outcomes, we may not see them today, we may not see them next month or next year, but where do we want to go? And so when you look at a chart like this, what are connected care? What's an intelligent supply chain? Hospitals, providers, and offices of health outcomes need to think in that long term and then work backward into the shorter horizons so we can have milestones for achievement that allow us to reach those outcomes. And so as I close, next slide, I wanted to talk about intelligence-driven organizations. Microsoft is about the size of the Virgin Islands. It's 120,000 of my closest, dearest friends, and I will miss them. I won't, I'm good. But when we look at that, we want to start with an executive culture. And so the governor spoke eloquently. Michelle has spoken. We heard from the commissioners. What is the top-down approach? Then we figure out what are the business cases. How do the business cases drive what we'd like to do? So that is healthcare, that is telecommunications, that is agriculture. What's the technology? What's in place? And then what do we need? And how can we drive that? And once we figure that out, we design operating models that allow us to achieve those outcomes. And so the last slide, this is how we actually drive looking at that. Next slide. Yeah, there we go. Okay, so we have, nope, too far. We have that executive, yes. So that executive, think of it as the CEO, the governor. Wait, no, back. We were there. We have the CEO, but the governor and the commissioners and members of the cabinet. The COO would be the chief operating officer if we think about it as a business. But those are specifically the department heads and down, those people on the street who are making it happen. The CTO, the CIO, what technology do we have and how can we drive that interoperability? And once we have those operating models in place, then we can start measuring and monitoring the metrics that help us to understand the efficacy for the individuals when these programs are put in place. So with that, I think we all want to take a deep breath and we want to hear what some of these folks have to say and how they can also lend what they're doing to this conversation as well. So we didn't really talk about how we want to do questions, so I'll start. One of the first questions that I will ask is, in your own experiences, how have you started looking at breaking down some of those barriers across the silos? The intelligence-driven organization is about breaking down those barriers and those silos. What are some of the challenges that you've come across and how have you broken down some of those silos?
Sure, I can start. Hi, everyone. Lisa Ekpo, Deputy Territorial Epidemiologist for the Virgin Islands Department of Health. My perspective is a bit different than maybe some of my panelists here, as it's focused on more epidemiology and surveillance. And one of the challenges that we were having in terms of establishing baseline data to drive some public health initiatives forward is underreporting of nationally notifiable conditions. So we've made great successes over these past few years with some of our wonderful providers who have consistently reported COVID-19 data to help us develop reports and use that data to help navigate the territory through the pandemic. And now as we're moving into the endemic phase, we're starting to see some of that data slow down and working with our providers to try to encourage continued reporting of the almost 70 reportable conditions that are required by law to be reported. The reason for some of these challenges and underreporting, we have a lot of smaller providers. So single practice or single physician offices with small staff, not a robust EMR system. They're unable to link directly to our reporting system. And that puts a great burden on them sometimes when it comes to having to fill out forms and fax them in, which we do still fax because some of our providers have that capability. And working to meet them halfway. So a couple of the things that we've been doing is in a community as small like ours is not infeasible to go office to office and sit down with providers, sit down with front desk staff, talk about the notifiable conditions, how they are to be reported, et cetera. And here's some of their concerns in terms of some of the barriers to reporting. Two of the things that we were doing, and I'll go through this quickly. We have been accepting reports in various formats. So I just talked about faxes. We accept emails, various Excel formats. However you want to send it, we'll take it, we'll reformat it, and then we'll put it into our system. And currently we're working with Hummingbird to develop a online form that mimics our paper reporting form, so that facilities who don't necessarily want to have to fill out those individual forms and upload them one by one or fax them one by one can do some sort of a bulk upload of their data, and that will feed directly into our system. So a lot of meeting our providers halfway, because we know that there are a lot of differences in their abilities in terms of what they can do in terms of capacity in their local offices. So that's our local perspective in terms of EPI and surveillance.
Hi, I'm Michelle Zankin. I'm a clinical analyst. I work with Zane Networks. In my work there, I wear multiple hats. My primary... In my primary role there, I work with, I get to do the fun job of, I'm a nurse. I've been a nurse for 30 years. And I get to do the fun job of making sure that my technology team is building stuff that we can use. I always say, it's like if I went into my mechanic's garage and organized all of his tools the way that I think that they should be, and then expected him to work for a full day. Wouldn't happen. I'd have them color-coded or by size. He wouldn't be able to find anything. And I think with digital technology, we really have to take that into consideration. If you don't have providers who are willing to use the technology, then we're all going to stay in silos because it's all going to be in SOAP notes. If they have to do 11 clicks to document an advanced directive, guess what? The last sentence of the SOAP note is going to say, advanced directive options reviewed, patient states they have one at home. And that's, we can't, without the AI and the machine learning, that's staying right there in that SOAP note, and we can't capture it to find out what our real needs are. I also work with the INC programs that Dr. McCoy had brought up. We support that effort with the technology. We work in trying to break down those silos and with the promoting health equity by developing a screening tool that can be either person-facing, so that a person can keep their private information and they can put it into that survey themselves without actually having to talk to somebody face-to-face, if that's what they choose. It can also be supported by a provider-led assessment, if that's what they need, giving those options out there available for the person to decide, the individual. That data is then taken from the screening into a team. So the INC program has got multiple different models because it's innovative. So the one model that we're working in, it is like a birth through 21. They pull people in. These children are pulled in. They work with the child and their families, and then they work with them all the way through until they age out at 21 or they move out of the jurisdiction that's covered. Whereas one of the other models is they're only intending to work with the individuals for roughly 6 months, for a 6-month period. Pull them in and get them out to the community services where the care management will happen there, make sure that they're in the appropriate services. So all of that pulled together, the innovation and having that technology to support those innovative plans, that's how we're going to break these silos down.
Hello everyone. My name is Boyd Mark. I'm the guy with the backwards name. If it sounds confusing, it is. Mark is my last name, Boyd is my first name. I'm the program director at the Southeastern Telehealth Resource Center. The consortium of telehealth resource centers are 12 federally funded telehealth resource centers that are responsible for supporting all 50 states and U.S. territories. In the Southeast, we're responsible for Florida, Alabama, Georgia, South Carolina, Puerto Rico, and the Virgin Islands. And we are an absolutely free resource that is available to any practice, any clinic, any school that would like to put a telehealth program in place. And we do education, we do training, really anything that we can do to help you or your colleagues put a program in place, specifically with a focus on supporting underserved communities and groups that are having trouble accessing healthcare. And thank you very much for the opportunity to be here today. When it comes to where are there barriers and silos, that's the kind of thing that we work on every day. And I'm not a military guy, but I think in the military they say a target-rich environment. There are lots of places to target silos. I think about providing care in non-traditional areas. That's something that we've talked about. For example, doing telehealth programs in schools. We work with a lot of schools, and one of the barriers that comes up is the resistance sometimes from the local provider community, who see that providing care in the schools, perhaps with distant providers via telehealth, is a competitive threat. And so we work with schools and local provider organizations to bring them together, because everyone really prefers if those distant providers are local providers, and it's just as effective as if a clinician is across town as it is if they're 500 miles away. So that's one of the silos that we find that we work on quite a bit. Another area that we often find is even within organizations. We work with a lot of clinics and rural hospitals, and initially healthcare and interoperability is set up as an IT project. And to your point, the IT folks do a great job, but they don't know what the clinicians need. So we'll come in and we'll do workforce training to help find that balance between where are things that need to be maintained on the IT side of the house with regard to compliance and security, and where do we need to empower the clinicians and the administrators to use the tools as they see fit. Other barriers include rural hospitals and small clinics that are trying to get their EHR systems up to speed and may not have the funds for a certified EHR system, and are therefore missing out on incentive opportunities or the ability to integrate. Those are all areas as a resource center that we can help with, and if anybody would like to talk about those things further, please let me know. All the services we provide are completely free, and we're HRSA funded, so we're here to help. Thank you.
All right, so I'll ask another question. Coming out of COVID, we saw a lot of transformation because we had to. There were a lot of best practices that were out there. However, they were not widely dispersed throughout the communities. And so I would love if each one of you can talk about one technological innovation, and I'm going to use quotes here, innovation that became prevalent during COVID. It probably already existed, but it has really helped to transform things the way that you're seeing them, and you hope, per some of what Dr. Ford was talking about, they don't go away.
Am I on? Okay.
Yes.
I can speak to, I think, I like that you put technology in quotes, because I think we recognized during COVID that if you want to help families, if you want to help children, you've got to include the school systems. That's where we were distributing food, that's where we were distributing access to Chromebooks, that's where the kids got tested, that's where the families came to get vaccinated. We use the schools and recognize the value of those school systems. What I'd like to see in the next steps is I'd like to see a shared standardization of data. We don't need to tell the schools and the education systems how to save their data, how to keep their data, but we do need to have a common set of information that can pass between service providers and these schools, because absenteeism data has got to be part of healthcare for children. It's predictive. The research is out there. So I'm hoping with all the work that Sandra Ford has done that we're going to be able to see that continue.
Very quickly, I would say the big thing that we saw in telehealth during the pandemic was what I would call the crossing the chasm event, where there was a realization between providers and patients that consumer equipment, for the most part, can be used very effectively for telehealth. It does not have to be a super intense cart, especially for mental and behavioral health, which is so important. Tablets and cell phones can be used, and they can be used very, very effectively, and that's something that just was not top of mind for people, and it is now, and I think that's a big breakthrough.
And from our perspective, reporting and working with entities that we hadn't worked with traditionally before. So schools now have the capacity to report their test results directly to us and communicate directly their system to ours. Correctional facilities, our police force, other government entities all have the capability to do their COVID-19 testing on site, report directly into a system that we develop, and that feeds directly to us. So for us, it's continuing to build on that, continuing to loop different entities into reporting into our systems as a way to improve interoperability community-wide.
All right, well, I guess on behalf of everybody here on the panel, my fellow presenters and esteemed guests, we'd like to thank everyone for the opportunity to talk about some of these topics. Again, thank you to the U.S. Virgin Islands Office of Health Technology, Michelle Francis, and the governor. This has been a fantastic opportunity, and I'm sure that everybody would love to chat more about some of these topics. So please find us, corner us, ask us questions, and we hope that we can be impactful. Thank you.
I did warn you that flexibility was needed. Thank you, Dr. Rwanda, for your flexibility and being so knowledgeable that you did not need a presentation. We do apologize. So I wanted to give the opportunity. We have a few minutes. We've got about 5 minutes, so I wanted to give the opportunity for 1 or 2 questions from the audience for any of our folks up here on this panel. Last year when we put people on the spot, this was kind of what we were met with. So when we thought about Q&A this year, I was like, no one liked Q&A last year. We had to incentivize with jewelry. Are there any final thoughts, especially from those of you that presented, that you'd want to leave behind? Dr. McCoy.
Is this working? I think I had to switch it. Okay, great. So I just wanted, there was a couple things I just didn't have time to get to. I wanted to talk about just a couple of pilot projects or not so pilot projects that are happening around this issue of consent. Because I think this is really important. Again, we've got to unlock legally the ability to move the information around that many of you in the room are working to be able to move. And so first I wanted to bring up a not-so-pilot project, which is the state of California, under its new Medicaid waivers, has created a really, really bold vision, again, for connecting medical care with a wide variety of other services, including people coming out of incarceration, who, as we all know, that is a highly inequitable system, and it sets them up for a lifetime of failure in a lot of different ways, but including with their health, but also housing, jobs, of course, many other things. So, and then behavioral health being another big issue. It's inside of medical care, and yet it's been siloed in order to protect people's privacy. And now we've gotten to the point where we recognize that that's not always helpful, that it's really important for people to be able to talk about their behavioral health issues and to get the supports that they need across the board, again, whether that's at work or wherever. So in any case, the state of California is piloting a program which has this great acronym. For once, an acronym is great. It's called Ask Me, and I can't tell you what the acronym stands for right now, but they are piloting a consenting process to be used across California's counties, and getting a lot of very, very local input from people, and I think that that's just really, really critical. And so I'm helping to follow that process for the California Healthcare Foundation, and to really try to move that forward and help unlock this interoperability that we want to do. And then on a smaller scale, a couple of projects I wanted to mention, because I hope that these are things that will inspire people. One is a project in the Bronx in New York City to connect the early childhood system called early intervention, which comes out of the Department of Education, to the medical care system. So again, when we as physicians see a child and we're concerned about their development, sometimes we send them to other doctors, but what we always do is send them into the early intervention system. And that's because not all children have insurance, and have good insurance and have access. So the early intervention system unlocks a lot of services for those children, but it is then completely siloed from the medical care system. And that needs, and parents are just bamboozled by this. They just can't understand why everybody doesn't know what's going on with their kid and the evaluations that have been done and the therapies that they're getting, et cetera. So we're trying to bring those back together, again, through a consenting process to get that started. And the last one is in Minneapolis with Hennepin Health, which is one of the Medicaid managed care companies in Hennepin Health in Minnesota, and really working with the homeless management information system and all of the homeless care providers for folks there to, again, bring their health care and their housing situations together. Maybe it's better for them to be getting pharmacy follow-up in their supported housing that they're living in. That might be much more effective than having to come to a doctor and figure out how to get there, et cetera, to get the health care that they need. So again, this is sensitive information. They have to choose to want to share that information, and we're helping to enable them to do that so that they can unlock a coordinated set of services. So I just wanted to bring up a couple of examples, hopefully for inspiration to people about similar things that could be done here in the islands.
Thank you. I would also want to add something I didn't mention in the presentation, is that we're working on a pilot project here with Roy Leslie Schneider Hospital. So we're going to be supporting a transition of care project that's going to be telepharmacy supported. So we're really looking forward to the outcomes of that project. And we're excited to bring our team here and CEO Tina Comision's team, working closely with them to make sure we actualize this project. And so we're excited about that. I also wanted to touch on sort of the importance of this, health information exchange, and a lot has been mentioned about CRISP. And I really wanted to give a special shout out to Craig and his team, because our telepharmacy project and providers in DC are extremely grateful to have CRISP DC, which is a part of CRISP Shared Services. One of the wonderful things that the system has is you're actually able to capture SDH data inside of the HIE, where it's now shareable with everyone. So everyone doesn't have to rescreen and re-traumatize, in a sense, our patients. So very, very valuable tool, and I'm so excited to see what CRISP will do here. And so I just wanted to make sure I mention and thank them for their innovation and their support.
Thank you. I do have one final question for anyone who might want to answer it. I kind of feel like Damon might be a prime target for this one. So for others in the room who serve in verticals, industries, kind of surrounding healthcare, what is the business case for a lot of what we're talking about for interoperability? So we've given the passionate healthcare foundation that we want people to be healthier, and it's more expensive when they're not healthy, and it's not equitable when they're not healthy. But we have a lot of folks who just need to hear the business case. What would you say, and again, anyone can answer, but I'm going to target you first. What is the business case for interoperable systems?
Okay, one of the transformations that we are seeing in the industry is the integration across industries with healthcare. So if you think about CVS, Walgreens, and the the combination of retail coming into healthcare. That's very powerful because it's not just retail coming in, but it's healthcare going into the retail space. So more healthcare, the clinics, I got my vaccinations at CVS. And you say, well, you know, it's a pharmacy. But several years ago, that might not have been as conceivable a notion. We are also starting to see manufacturing more so with driving healthcare outcomes in plants and medical plants. Manufacturing plants. To be able to say, hey, look, instead of you taking a sick day and going to the hospital, what if we could just treat you here at the plant? We're starting to see that more so in the military, and I would love to see, I did some work with DHA, the Defense Health Agency, where we look at servicemen and women from the day that they enlist to the day they retire from service. And we know everything about them, but how could we have more predictive and more interoperable engagements around that healthcare with them? And so DHA has been starting to look at some of that. So there are a number of ways that we can save dollars, and Dr. Ford talked about some of the cost savings that we see. Different industries are starting to think about that as well. And they're starting to pull that in-house, and they're realizing that there are some tremendous benefits from continuous patient monitoring, from genomic screenings and genetic screenings, to pre-identify the potential that an individual could be predisposed to cancer or diabetes or some of these other things. And when the SDOH is engaged, then we see that the likelihood could go up. How could we make them more productive by keeping them healthy and keeping them working? So those are some of the things that I've seen.
Thank you. Thank you all for your time. So that you know, the presentations will be made available online. So this is my shameless pitch for visiting the website. You can only find these presentations at www.ohitusvi.com. And also, we do have some special gifts available for those who follow us on Twitter and follow us on Facebook today. So make sure you follow us. But I do want to put out there, Dr. McCoy, that I do believe there'd be any number of interested parties from Human Services, from Department of Ed and Department of Health who would like to talk more about some of these pilot programs that you're doing. There's a system, I'm going to put our Chief of Staff on the spot. Do you want to maybe just mention Vivis? Some of the things they've mentioned, I think, can help give benchmarks to what's being reactivated there, but I don't know if Sana, if I can put one of you on the spot. But I would say there'd be interest at least in hearing what is being done in California, all around the country, as we join. You want to at least explain what it is?
Hi, good morning, everyone. So, as Michelle is explaining, Vivis, it's a longitudinal data study or data survey that we've been toying with for the last several years. We utilize it mostly from an education perspective, really tracking students from the time they enroll in the public school system until the time they actually exit, whether they go off to if they go off to the local University of Virgin Islands, we track them a little bit longer, but then we sort of lose them out of the system. It actually has the functionality to be able to track folks, quite frankly, from cradle to grave. That's the manner in which we hope to extend its utilization. So recently we've transitioned from the Department of Education maintaining that database. We're now transitioning that over to the Office of the Governor, so that we can bring more agencies in on that data collection and start to track individuals from the time they're born, so we can track health outcomes, track them through the health system, through our social service system, through education, of course. We can track them post high school, where we look at their workforce development and other things. So all of those social determinants of health we can actually track through the VIVIS system, and so we're trying to build out the manner in which we can do that. So that will certainly dovetail with some of the work that you're doing here with the health information technology, particularly the health information exchange. So. Sure.
Yes, there we go. So I'm curious, as it's so important, obviously, to study things at a population level. So my question is, are you using that data at this point in time, essentially at that sort of population level, to understand trends and be able to put resources where they're needed at a population basis? Or are you actually looking at that in terms of potentially being able to intervene for the individual child and family?
So at the end of the day, we want to be able to intervene. Right now, we're using it for trends. So the Department of Education sort of uses it for to get ideas as to where they want to put intervention programs, what sort of, it's particularly the intervention programs when they look at outcomes from an education perspective. We really want to get to a point where we're looking at it from a case management perspective, where we're looking at the individuals, not just looking at the overall data for the trends, but really looking at how do we intervene with individuals early on when we see that there's things happening in that individual's life that perhaps we can intervene and fix. So we might be having poor education outcomes because of poor health outcomes. It might be social issues. And so we're really looking at the fact that we have a very small population. And if we have a very data-rich environment where we're collecting a lot of data on a very small population, and that allows you to, for lack of a better term, manipulate that population, do some social engineering, and really sort of intervene into the lives of individuals and avoid some of the worst outcomes on the back end. Hi, Dr. Ford? Well, we have to work through those issues. You know, Dr. Ford wants to know how we manage consent. So as of right now, you know, it's just data. We don't tie it to individuals. Consent is the hurdle that we're going to have to overcome as we try to broaden. So we have this wonderful platform that we can utilize in a really great way, but we do need to work out what data we can use and share, and how do we manage consent from individuals. You know, what part of it is voluntary, what part is involuntary, and what we can and can't do. So that's the stage that we're at right now, actually. Commissioner Canisiung. We're on, yes.
Okay.
There we go.
Brad is telling me of patience. Okay, so really just a link with what Dr. Ford said, because looking at what and asking for permission is one thing, but looking at what it really means in terms of HIPAA and redefining HIPAA, because like she said, everyone, the minute you hear or think about sharing information, they are so cautious, but really and truly, all that information is already out there. So that's where the trust and the comfort level actually comes back in. And I think the more that we actually do it, the more individuals, and share with them, when you travel to the mainland, that they have information that's shared all the time, your information stays there. Your information goes elsewhere. So we just have to become a little bit more comfortable with what we do based on the conversations we've had before.
Right. Definitely. And you know, I heard it mentioned a couple of times, it is a small town, so we know, you know, in the Virgin Islands, we're 2-3 degrees of separation away from each other in many instances. So that is a concern, but that also lends itself to can we trust each other as a community to make sure that we are providing as much support to each other for better outcomes. So there is a possibility that, you know, once we can show that the information is properly safeguarded, we can get folks to opt in many regards, because they do trust that we have their best interests at heart.
Yeah, I just wanted to comment that that's amazing, and applaud your efforts in that way. I feel like the Virgin Islands has got a unique opportunity to show the rest of us the right way to do it, because you can actually touch each single person that you're working with, and you can say, oh wait, this didn't work because of that. fix the system. Oh, wait, this didn't work because of that. Fix the system. We're guessing.
Right.
And I applaud your efforts. That's amazing.
Well, thank you very much. Answers your questions, Michelle?
Yes, thank you.
All right. Enjoy the rest of the summit.
I enjoyed the opportunity to put Chief of Staff on the spot. Thank you. Thank you all. This was actually a great setup for our next panel. Eddie wanted me to let you know, if you scan your barcode again, we've updated the agenda, but we're going to talk about interoperability and digital transformation, the critical imperatives for stakeholder data exchange from the folks who are writing the rules around this. So thank you. We'll have you guys make your way off the stage. We're going to be moving right into this virtual presentation. The question just came up. How do we do this? How do we get permission? How do we know if it's safe? Does HIPAA allow it? Does HIPAA even apply here? We're going to be hearing from Lee Barrett. He's going to be moderating a panel with some of his chosen peers. Lee Barrett is the Commission Executive Director for Direct Trust. He previously served as CEO and Executive Director for the Electronic Healthcare Network Accreditation Commission. So any of your questions around, especially in this electronic healthcare network, what are we allowed to, what can't we? Lee has been leading the charge, working with ONC. He was appointed by the Office of the National Coordinator as FAST co-lead of the Testing and Certification Tiger Team and as a member of the Executive Committee. As I mentioned, he's currently the Executive Director for Direct Trust. You'll also be hearing from Marian Yeager, who is the CEO for the Sequoia Project. How many of you have heard of the Sequoia Project? Okay, very important to know what they do. It's a not-for-profit solely focused on advancing secure, interoperable, nationwide health data sharing in the US. So when you hear about the standards that we need to be not only aware of, but abide by. When you hear about certification of HIEs, certification of EMRs, electronic medical records, or electronic health records, how are they certified? There are standards that you have to meet. So we're going to hear from some of the people who not only drive these standards, but have helped develop them. So we're going to test and see, Media One, if we've got our virtual team online. Good morning and welcome to the Virgin Islands. Can you all hear us?
Good morning, Michelle.
Good morning, Lee. Thank you. Thank you, guys, for your flexibility. We're here on the ground so everyone knows kind of what's going on, and you guys have had to sit patiently to know when you get the 5, 4, 3, 2, 1 come in. So thank you for coming in. I don't know if you heard the introduction, but now the burden is on you. We've talked and heard from Dr. Sandra Ford. We've heard from Dr. Christine McCoy. We've heard from Dr. Maria Wanda, all about work that they are doing in specific spaces to help address issues of health equity through improving the way they exchange data, they share data, collect data, in order to get a better view of the whole person and treat them. So questions just came up after our last session about, so what is allowed by HIPAA? How do we know what can be shared? How are you collecting data from people, and how do you get their consent? So I thought this was a perfect question leading up to all of you sharing on the rules of the road and the standards and because we're not doing this in a silo, we're not doing it blindly, so I welcome and thank all of you for being here so that you can share with us kind of what those guardrails are. I'm going to ask you each to give a little bit of your bio so I don't eat into your time by sharing that. But I shared a little bit about you, Lee, and also you, Marianne. So I'll let you lead off, Lee. Thank you again for being here.
So thanks, Michelle, and thanks to the governor and for the Office of Health Information Technology for inviting us all. So we have a stellar panel here as you were kind of going through, and I am going to have each of them is going to have an opportunity to kind of go through and introduce themselves. I will go through their names quickly to introduce this panel, and then they're going to each have the opportunity to kind of go through as well, introducing themselves, their organizations, and kind of their initial perspectives on interoperability. But what a great tee up from the last session, listening in on that. So it was a terrific panel. So who we have on the panel, as you mentioned, we have Marianne Yeager, CEO for Sequoia Project. We also have Tim Pletcher, who is the Executive Director for the Michigan Health Information Network. We have Avinash Shanbhag, who is the Executive Director for the Office of Technology for the Office of the National Coordinator. We have Scott Stewie, who is the CEO for Direct Trust. And we have David Lee, who is sitting in for Ryan Howells, who's from the Levitt Partners, the Karen Initiative as well. So David, good to have you as well. So that's our stellar panel, and really what we're going to be doing is to really have each of them kind of go through kind of a quick overview, as I said, introducing themselves, their organizations, the role that each of them are playing in interoperability, and kind of their initial perspectives on interoperability as well. Then what we're going to be doing, I'm going to be moderating and going into a fireside chat with everyone. I've got a number of questions that I'm going to be asking. Then we're going to have time for all of you to as well ask some additional questions as well. So that's kind of the format for our fireside chat here. Before I kind of turn this over to Avinash to kind of start us off, let me take like a couple of minutes to kind of set the tone, the context on interoperability for many of you on kind of where we've been as far as the interoperability roadmap, and kind of then we're going to be discussing obviously where we are today and where we're going. We want to spend a lot more time on the kind of the future of interoperability. But as many of you know, decades ago, really all medical records were physical charts that were stored in giant spinning circular wheels in hospitals. Remember those days? And when we tried to look for those records, when they tried to get those records, files and records were not only hard to find, but in many cases they didn't have much in the way of medical history on them at all. As well, referral notes got sent in the US postal system from point A to point B, so we spent days waiting for referrals. The fax machine was introduced, and guess what? Still being used today in many settings. But kind of that was kind of the way in which we were looking to exchange a lot of medical information on patients. The 90s really brought really a big advancement in the use of electronic health records. They became far more widespread then, and then in 2004. You know, we had the Office of the National Coordinator was actually established by an executive order. In 2009, we had the Health Information Technology for Economic and Clinical Health Act. How many of you wanted at least 20 new acronyms out of this? You'll get them on this out of this panel. So that was the High Tech Act at that point. And then also the American Recovery and Reinvestment Act came into play, so ARA. Then in 2016, we have the 21st Century Cures Act, which was passed by Congress, by a bipartisan Congress at that time, which was fantastic. And then, you know, in 2018, we had the Centers for Medicare and Medicaid. CMS started the Health E-Data Initiative, in which then acting Administrator Seema Verma stated that this initiative aims to empower patients by ensuring they control their healthcare data and can decide how their data is going to be used, all the while keeping that information safe and secure. That really kind of set the tone as well for kind of this healthy data initiative. Over the years, we've had a number of additional initiatives and standards and regulations that have been established, including the development of the Fast Healthcare Interoperability Resource, or the FHIR Application Program Interface, API, as well as the Common Clinical Data Set. So that kind of sets what some of the things that have occurred here that are continuing to go through. We've also had the blocking rule. We had TEFCA that was actually signed, the Trust Exchange Framework with Common Agreement, which really is a big piece. And again, you're here, Mary Ann, the Sequoia Project was selected as the recognized coordinating entity and has been coordinating that for ONC for a number of years here. Then we had, we have organizations like Health Level 7. We have a number of coordinating entities as well that are going on. HL7 having responsibility for the FHIR API. And lastly, the other thing I think that's going to be important you're going to hear from us is really the strong collaboration between both at the federal level as well as at the private sector level, between not only Office of National Coordinator, CMS, Office for Civil Rights, the Federal Trade Commission, the Center for Disease Control, many of these, and you're going to hear Avinash as well as Mary Ann probably, as well as many others, kind of talking about all the coordination efforts that are going on here. So with that kind of provides hopefully some context on where we've been. So let's talk about now, let's turn this over to Avinash to kind of go through and ONC's perspective here. So Avinash, let me turn it over to you.
Thank you very much, Lee. I just wanted to check whether the audio is coming across well.
Yes.
Great. Thank you very much. First of all, again, on behalf of ONC, I wanted to thank the U.S. Virgin Islands and the Digital Health Summit for inviting us. It's a privilege. Also, it's a privilege to participate in this really fantastic panel. I think I'll say from a government perspective, and I'll give a little bit of background on the work we do. We really depend on the work that this panel members and their membership actually works off. So really, I think this is a joint effort, as Lee mentioned, that we as government wouldn't be able to move forward on a lot of things that, frankly, the customers, the patients are really interested in doing. So a little bit of a background from ONC, as Lee mentioned, we were established in 2004. And really, the first decade of our activities were involved in the building of our certification program, which really established the base, I should say, think of as the base framework for digitization of health records, again, going from paper to digital records. And my office does manage the certification program. And again, just from statistics perspective, over the last decade or so, about 95% of hospitals use electronic health records that are certified by ONC and ONC certification program, and about 85% of providers use them. So we have digitized health records, but have we really obtained value? I mean, that's an open question. And really kind of one of the goals of ONC in this next decade of our work. We are about 18 years old, so finishing up our next decade of our activities and moving on to the third decade. The focus of ONC's work will be to kind of gain value in all that digitization activities as well, really to find value in EHR technology and really one of the areas, and that kind of gets into the areas of focus where ONC works on. I think one of the primary areas is to make sure that that health data that is captured, collected, exchanged by electronic health records are usable. So we spend a lot of our effort in standardizing that data. We have in our certification program a data set we call as the US Core Data for Interoperability, the US CDI. And think of them as like the basic foundation of a health delivery system, and that constantly grows. So that's one area where we feel that as data gets standardized, health data gets standardized, it can be leveraged for a variety of uses, for social determinants of health, for making sure that, as I heard in the previous panel, when you can get now vaccines from non-traditional health facilities, those are, again, enabled by standardized data. Now, again, we know that as a healthcare delivery system, there are lots of programs that require lots of different data, and really, we can't really have EHRs or a general platform support all use cases. But again, as another part of ONC's effort is to build off working with our federal agency colleagues to coordinate building out the needs of special data sets for the old programs. I think example would be like public health. I think there's a lots of work on public health, and there's a lot of needs of public health that really are not obtained through this basic data set. So there's a work that's going on within ONC called the US CDI Plus, which I can discuss in this panel later on, that really starts working with coordinating with federal agencies to make sure that their needs and really the broader needs of health and human services for data get realized working with those agencies. And again, the base idea being that we want the electronic information to be not just utilized by providers for treatment purposes, but really for operations and other betterment of healthcare, which is really very crucial. So that's kind of one area to kind of like focus on. One other area I'll talk about is that's data is one level. Networks are also important. And really what I see in this panel is this a group of organizations that have been actively working to make sure that the last mile gets connected and is able to talk across the entire geography. And where ONC's work really has been is to kind of think of it as like the network level governance. So you can think of a high level analogy would be like making sure that Sprint network and Verizon's and AT&T are all able to talk about it. And that work has been led by Sequoia, and Mary Ann Yeager is leading the work through what we call as a trusted exchange framework and common agreement. And really at a high level, it's make sure that the connectivity across network is got the level of trust that is needed for all the participants to be able to actively work on. So that's two main areas. And one final area I will talk about before we kind of move on to the next panelist would be, we are actively working in this decade of our work, and we have a proposed rule, which I would be remiss if I didn't mention, so please take a look at it. The proposed rule has a deadline for submission of comments for June 20th, so it's coming rapidly. Really, the focus of that proposed rule is to start making interoperability easier. And some of the things that Lee mentioned about APIs and the FHIR standard are all activities that go into kind of making sure interoperability is easier. And also some of the harder challenges get discussed. So I think you mentioned about consent and the difficulty and challenges of consent that is still prevalent in this existing interoperability environment, even in the presence of HIPAA, which really does require a lot, that provides a lot of flexibility. In our current proposed rule, we have lots of proposals around consent management and across like the spectrum of both security, risks, and patient access. And again, encourage the folks that are listening in to again take a look at our proposed rule to make sure that it would convey to us how best we can overcome the challenges that you all see in your day-to-day life. So I'll stop there in terms of just my opening remarks, but just closing in, we are actively working on making sure that interoperability is as smooth as possible. We are looking at challenges for use of that data. And again, we want to make sure that access, exchange, and use of health data for betterment of healthcare is as a universal privilege and ability that can happen all the time. So with that, I'll turn over to Lee again. Thank you.
Thanks, Avinash. Appreciate it. Tim, why don't we go to you?
Hi, I'm Tim Fletcher. Do a quick sound check too as well. Make sure you can hear me. Okay, so I'm the founding executive director for the Michigan Health Information Network, or MIHIN as it's called. And Michigan's got about 10 million people in it. And we were founded in 2010 with funding from the Office of National Coordinator. So we are very much one of those state designated entities that was launched because of the Office of National Coordinator. And we've had the good fortune to really be successful over the last decade by really getting the right combination of public and private partnership happening. And that's certainly starting with public health use cases. Our very first use case was around immunizations, which turned out to be very beneficial during COVID because we had a pretty mature infrastructure to sort of build upon and take advantage of. But we also found that the private sector, those commercial groups, were very interested in care coordination. And so we spent a lot of time on motivating financially and through whatever means possible data exchange, and really focusing not on folks connecting to the network, but drilling into specific use cases that created value. And some of the first use cases that we focused on were things like alerting that somebody had been to the emergency department or been to the hospital, and then built on that use case to stack up other kinds of care coordination activities, but also results reporting, and then moving into other areas like quality improvement. So making sure that we were doing things that started to reduce the burden on providers for exchanging data, up to including, today compliance and really helping folks comply with 21st Century Cures Act activities that are trying to put data in the hands of consumers. Some of our current work is really focused around what we call cross-sector data sharing. A lot of people will include in cross-sector data sharing things like health-related social needs or social determinants of health. But one of the things that we found is as we go into other communities, we bring a strong healthcare bias. And some of these communities, whether it's education or social community organizations, they don't have the healthcare bias. I mean, yes, social determinants of health are very important to some of these community-based organizations, but their primary goal might be to feed people, not necessarily to improve their healthcare. And a lot of times when a big hospital or a health plan shows up in the community here to fix the problem, we just bring a certain perspective. And so our role has really been evolving from a health information exchange, which a lot of that emphasis was making sure providers had the data they need and that EHRs were interoperable, to a journey that we really now, certainly post-COVID, articulate as becoming a health data utility. And that's really becoming a very broad-based infrastructure that the state can rely on, that the nuances of local community interaction, any jurisdictional considerations that that sort of fall into the domain of the state legislature or the governor, those kinds of community-based activities are really met and addressed in that last mile, but in a way that the community itself embraces. And I think earlier you all were discussing sort of trust. A lot of that foundation for us for trust is built on the legal framework. It's built on the consent framework and the stacking up of use cases that enable higher and higher levels of functionality, so that we don't try to boil the ocean all at once, but we sort of do it a layer at a time. But then combinations of functionality allow us to tackle harder and harder problems. And so we've really been on this sort of journey of public health and HIPAA in terms of treatment, payment, healthcare operations. But then as we connect more pharmacies, prescription drug monitoring systems, going into schools and worrying more and more about behavioral health and children's safety, we get into more sophisticated scenarios of consent. And I think this is a really big foundational future issue that I hope we'll talk about more, but it's this ability to deal with consent as it crosses sectors, where in healthcare we might be very familiar with HIPAA, then we have specially protected information when we talk about advanced forms of behavioral health and substance abuse. But then we have things like FERPA as we get into sort of school sharing. And then when we get into very sophisticated areas, we have sort of parental rights overlapping all of these things, particularly when we're talking about children's safety. And so there's this sort of cascading layers of trust and infrastructure and interoperability as we really put in a utility that solves a lot of problems to sort of keep people healthy and well. And so that's been our real emphasis over the last decade.
Thanks, Tim. Appreciate it. Mary Ann? You got us on mute, I think. Still can't hear. I'll tell you what, while you're doing that, why don't we, Scott, are you there? Mary Ann, got it?
Sure. Yeah, can you hear me?
Yep, there you are.
Can you hear me okay? Good. So I'm Scott Stewie. I'm president of Direct Trust. You can hear me okay?
Yes.
Oh, good. Okay. So Direct Trust as an organization basically lives in the same ecosystem that everyone has described so far. So Direct Trust grew up in the same time frame. So we're basically about 11 years old. The organization was again, funded initially by the Office of the National Coordinator, and our activities were really focused initially on direct secure messaging. So direct secure messaging is the capability to send, particularly for referrals from point A to point B, getting the information about the patient to be very, very specifically differentiated from a query. Query is sort of the patient is in front of me, where are their records? Push messaging is, here's what I would like you to know about my patient. But so since I've arrived at Direct Trust, we've really tried to pivot our focus from specifically on direct secure messaging to a general notion around the foundation that we laid for direct secure messaging for technical trust. So trust has been mentioned by everybody everybody will say trust on this panel, and it means the same thing to all of us. Let's clarify that for sure. Like, we're not talking about 2 different things or 5 different things, but there are layers, as Tim suggests. So the layer that we're talking about is the technical trust layer. So can I know who I'm talking to across the internet and reliably be certain that a patient is who they say they are across the internet? And so it's for things like authentication and trust in identity across ecosystems that are extremely highly connected, so and increasingly connected. So as we roll out TEFCA, there's going to be so many more devices and organizations that are now connected. This, from an organizational perspective, exposes folks to new risk. So the way in which we manage the risk associated with making connections happen is this layered trust model. And a part of that trust model is ensuring that people are all behaving according to the same basic rule set. Some of those rules are rules that are established by trust communities like TEFCA or like the Health Exchange or like Care Quality, but those are more focused on the agreement elements. What we're focused on is the technical element that rides underneath that, and so we actually provide that capability today for direct secure messaging, but also for Care Quality and for eHealth Exchange and for TEFCA. So those certificates that are issued for those purposes come from our organization. The other thing that we do is we do independent certification of the capabilities of organizations to ensure that they know that their exchange partners are cyber healthy. So this is actually a very key part of the risk elements. So Direct Trust merged with ENAC last year, or at the beginning of this year. And so that's the reason that Lee and I share the same shirt. But we grew up as separate organizations. ENAC grew up as an organization focused on that accreditation problem. And that accreditation element is a key element for, for establishing the trust. So it's not just accreditation, but also the assessment of the QINs themselves. And in that regard, the RCE and ONC has established high trust as a requirement for the QHINs and their participation. And so we are also a high trust assessor. So as a broad part of the ecosystem, in support of the overall trustworthiness of exchange, that is our role, is to be underneath all of these things we're talking about, all the use cases we're talking about, but we're also passionate about all the same things that Tim described. we are a membership organization that convene folks to talk about these use cases and these challenges. And so we're very excited to be a part of this panel and really eager to hear what everyone has to say.
Thanks, Scott. Appreciate it. While we're waiting for Mary Ann to come back, David, why don't we go over to you to talk about, and there's Mary Ann. Why don't we start with you, David?
Great. So I'm here representing the Carin Alliance, CARIN, and the Carin Alliance is one of the HL7 fire accelerators that's focused on the consumer use cases of information sharing. And we were started similar to some of these other organizations about 7 years ago by two former Bush and Obama administration officials, Anish Chopra, who was CTO for President Obama, and David Blumenthal, who was national coordinator for President Obama, and then David Brailer and Secretary Mike Leavitt from the Bush administration. And as I noted, we are focused exclusively on consumer-directed health information exchange. And so making sure that consumers, as we go through all of these activities to make it system sharing better and for TPO purposes, that sharing to work, and to make sure that networks can share with networks and their sub-participants, to make sure that consumers have access to the information that they need to make decisions about their health when and where and how they need it. And so we've talked about HIPAA already and some of the TPO use cases. We focus more on the individual access and the individual right of access under HIPAA for an individual to go to their insurer or their health provider and say, I would like a copy of my health records. And this has been a challenge over a lot of years. You went back before digitization and you had to go find the health information management department at your provider or go to the front desk in person and say, I would like some of my information. With some of the things that we've talked about already through FHIR APIs, through some of the other modern data sharing opportunities, there's now an opportunity for consumers to use an application. I think the one that most folks are familiar with is Apple Health, right? You can set up through Apple Health connections to your providers and say, I would like my information from various areas and pull that back in. That does create some challenges and some unique dynamics, some of which we've already talked about, privacy, right? When you invoke your individual right of access, especially electronically, you're moving your information from a HIPAA-covered entity into a consumer-facing application that's regulated by the FTC. And so how do we make sure that those consumer-facing applications have the right safeguards to protect your data? Carin has created what we call the Carin Code of Conduct. And we're working with Direct Trust on operationalizing this a little bit. But the Carin Code of Conduct focuses on what consumer-facing applications should do from a privacy perspective, from a consent perspective, from a data security perspective, and making sure that those consumer-facing applications are living up to the best things as they kind of facilitate consumer access for individuals. And I just note, we've talked a lot about a lot of the successes. I think a lot of the consumer groups that we work with, and we're a membership organization as well, with consumer-focused organizations and individual consumer advocates, hospitals, payers, technology vendors. One of the things that we hear from consumers is we've made a ton of progress, but we still haven't fixed a lot of my issues, right? And we start off most of our meetings with a consumer experience saying, when was a time where you wanted your information and you couldn't get it? And we've heard really challenging stories from folks with chronic conditions who, still have to carry around a binder of paper from provider to provider to say, this is what I need you to know about my last visit or my last exam, to very routine things like trying to get your kids' immunization records so you can register them for school, and a lot of confusion about what can be shared and how it needs to be shared. So as we talk, we're going to talk about system things and really important, TPO purposes and network reasons and how we share among providers and how we share among payers. And all of that is critical to the operation of healthcare. But I want to make sure that as we go through this, and I know we will, knowing all of these organizations, making sure that we keep the consumer, the patient, the caregiver center, right? Because all of this data flow is intended to make care better and to make the consumer experience better and to make people healthier. And that's certainly Carin's mission. And as everyone else has said thus far, I'm really looking forward to our conversation around how we do that.
Thanks, Dave. Mary Ann, let's go to you.
Fantastic. Can you hear me okay?
Yes, thank you. Yes.
Oh, thank goodness. Three times the charm. Yes, so pleasure to be here. What I'm going to be talking about today, the perspectives are really related to TEFCA, and we are working with ONC under a cooperative agreement. So I always have to declare that nothing I say is an official position of the government. And so I think a number of folks have already explained that ONC was directed in the 21st Century Cures Act to develop or support a trusted exchange framework and common agreement to enable the exchange between and among networks. And this is really in response to a lot of the pain points that policymakers were hearing about how difficult it is for health information exchanges, healthcare organizations to really share information without having to join multiple networks. And so the idea was that there was something needed to simplify that. So the goals of TEFCA are really threefold. One is to establish a universal floor of policy, governance, and technical requirements to enable that interoperable exchange. The second goal is probably, really foundational, and that is to make it simpler. To make it simpler for organizations to share information, to improve patient care, to enhance the welfare of populations and generate healthcare value. And third, and probably most importantly, this is an opportunity that TEFCA really brings to bear, is to make it much easier for individuals and caregivers to gather their own information. And so a lot of what you've heard in terms of perspectives from others on the panel really is consistent with the goals of TEFCA, and TEFCA is enabling that further. So how does this really work? Well, ONC is sets basically the overall policy direction and has certain governance requirements themselves that are inherently governmental. And so they are really the owners of this government endorsed approach to exchange of data. The Sequoia Project we're a nonprofit public good organization. We focus solely on issues around interoperability. We do a lot of things other than working with ONC on TEFCA, so I really am focusing just today on that part of it. But in our role as the recognized coordinating entity, we helped ONC develop the framework and now implement the framework. A lot of our work is actually evaluating and determining whether health information networks that want to seek this special designated status as TEFCA qualified health information networks, or QHINs, whether they meet the expectations for trust, for privacy, for security, whether they have strong operations, that they're financially sustainable, et cetera. And so the QHINs, once designated, connect directly to each other in compliance with this TEFCA framework to facilitate exchange of interoperable data, nationwide across all U.S. states and territories. Each respective QHIN in and of itself represents a number of connected healthcare organizations, which could be healthcare providers, it could be health plans, it could be individual access service providers or apps, it could be HIEs, which in and of themselves represent connected communities. And so the idea here is that the QHINs represent very high performing, high resilient networks that have received a stamp of approval that we, the Sequoia Project as the RCE, are the only ones who can facilitate. So where are we with respect to rolling out TEFCA? Well, we published the agreement and the technical requirements that QHINs or networks who want to be QHINs have to abide by. We published that in January of 2022. We opened up applications for QHINs in October of last year. There are currently 7 candidate QHINs that we've processed their applications, and now they're going through the next step towards designation, and that means they have to complete the requisite technical testing and also fulfill any outstanding issues in their project plans. So what does this mean to you all? Well, it should mean, once TEFCA is operationalized, that it's easier to get access to information for a multitude of purposes, to treat individuals, for payment and healthcare operations, importantly for public health, government benefits determination, and individual access. So I'll pause there. I'm sure there are a lot of other questions we might want to address.
Thanks, Mary Ann. Thanks to everybody for kind of your overviews. So let me start off our kind of our fireside chat here with an open question to all of you. So you've kind of set out kind of what you're all doing, and I kind of gave the background. But what are the challenges, the barriers that we're seeing today affecting nationwide healthcare interoperability today? And in the next 3 years, as the national roadmap is implemented. So again, I know Avinash ONC has kind of set out some of that roadmap as well going forward. So what are you all seeing as kind of the barriers and the challenges that we're facing to try to continue to move interoperability forward? Scott, why don't we start with you with your thoughts here?
Sure, Lee. So I think, everybody here has played a huge role in getting the last mile wired. The last mile is actually there's a lot of connections already in the ecosystem. We've had a lot of success actually between the health information exchanges, care quality, and Commonwealth making their connection over a couple of years ago. That's to my way of thinking, and I like to call it the OzBag, the TEFCA OzBag. So what is in the TEFCA OzBag for the biggest problem I feel like we have? So the biggest problem we have is the last inch, which I personally think, which is, we heard some folks on the previous panel talk about this, interoperable workflows are not terribly usable. And what's more, people don't even know they have these capabilities. This is actually true of any capability we're talking about. They don't know that they're connected to the HIE. They don't know that they have query exchange through Care Quality or Commonwealth. They don't know TEFCA is coming. They don't know how to use direct secure messaging. They don't know that there's anything to do but faxing. That's really the truth about today. So when you go out and you ask your provider, can I get sent from organization X to Y? And I say, oh, I have them. Can I send? They ask you to fax them to you, which is, completely ludicrous. I don't have it. Do I look like I should have a fax machine? Anyway, in any case, I do believe that's the biggest problem we have is actually education for what is possible. If people knew, I think the recs that existed in the first, and actually heard of a rec on this previous call talking about, HRSA funded capabilities around helping people. So this is something that we still need, and we don't have. We had it really in spades in the early days of trying to get the HR implemented. The rec was a huge asset, but this is, I think, our biggest issue. And it's every constituency in the market, particularly for business to business, though. I think consumer is another big challenge. The ability to produce, to make the ability for consumers to have single sign-on to get the access to the records. I think that is also a huge barrier because the current model around knowing your username and password everywhere you go is a big problem. It's so anyway, that's but usernames and passwords are a problem anyway. This is a focus of our interest, certainly. So anyway, that's my thoughts.
Okay. Marianne, your thoughts?
Well, Sequoia focuses on identifying and addressing challenges and barriers to interoperability. I mean, that's all we do and all we focus on. So there are lots of things I could sort of weigh in on, but the one that's top of mind, Lee, is really the challenges around data usability. I like to say that we've done a great job at getting indoor plumbing, installed in the U.S. and territories, but the water is not potable. And so we really have to fix that. So we actually have an initiative separate from our TEFCA work, of course, focused exclusively on that, very practically oriented. And so, we're really big advocates of taking incremental steps towards improvement. We think that the guide that we've come up with through our group last year is the way to do that. And we're rolling that out. But that's one that's really top of mind for us.
Dave, thanks.
Yeah, I'd echo usability and access, right? We've done a lot to have the pipes, but there are organizational challenges with sharing and a lot of it's confusion around HIPAA requirements and HIPAA rules. It's, your job is to provide care at the physician's office or at the hospital. And so under-resourced organizations especially have progress, and we've had so many good things happen with setting up the infrastructure to do it, but making sure that operationally it's happening and that consumers, that providers, that people in care teams have the information they need when they need it is, I think, the next big challenge as we move to operationalize a lot of the stuff that's happening and is really good already.
Great. I think we're also seeing, before I go next, I think the other aspect that came from the other panel is the whole issue around consent as well. We're still dealing with how are we going to deal with consent and make that as easy as possible for consumers and patients. Avinash, your thoughts?
I think all the topics that Marianne, Scott, and Dave mentioned really ring a bell for us. I think I would kind of pivot to saying that education and really I'll broadly talk about information sharing. Just like as ONC, we also have another regulation called the Information Blocking Exceptions Rule, which essentially is, again, what Congress did put in the law was that health information needs to be interoperable, needs to be shared. And with some exceptions that ONC put in our rules, there's a lot of interest in making sure information flows, but really I think the future is to make sure there's education to make sure that information is shared appropriately. There are all the questions around like making sure that the realities on the ground get reflected into a high level policy that ONC really reflects. And that's kind of where we need all of the folks on the panel here, because from ONC's perspective, we can provide a high level kind of policy framework, regulations, but then really the devil is in the implementations. And really that's what we are, I think, seeing in the future. One of the areas I'll talk about, data quality is an area of focus for us now that increasingly data is moving, that data is liquid. We really, the value of all that digitized data is when we start using that data to do treatments, payments, operations, to do all those outcomes and population health related activities that are really what everybody wants to do. And for that, we do want to make sure that both data quality from the perspective of what is required for all the various use cases are applied, and also making sure that patient matching and all the other things that really go into making sure that data cohort is appropriate does get balanced and appropriately addressed. So that's again an area for focus for us. And finally, again, as all the panelists here are working on the last inch, last mile, we are at ONC looking into the future for what would be the next 3 years around like the value of now assuming a vision of if all that data is electronic, is accessible through APIs, and is leveraged high quality, what next would be the area where we need to focus on. And some of the things I mentioned about in terms of adding in the higher level value added services on top of these electronic data through maybe adding in workflows, making connections with electronic prior authorization, which is a huge challenge in the payment area, working with our research communities with NIH to make sure that the research, the work and the monies and the resources that are spent on research can be leveraged across our population health. So some of the areas that's where ONC is now going to be focusing on is really like working with our standards organizations, working with organizations such as Karen Alliance and Direct Trust and the HIEs to pilot all these innovative areas of need, maybe 2 years from now, but hopefully by the time all that gets hardened, the floor is raised up to be able, and the needs of the people and providers, patients, all the various communities, kind of when they need it, the technology and the governance is there. So again, that's kind of like a future casting some of the things that ONC wants to do now for implementations in the future.
Before we go to Tim, thanks, Avinash. I'll put in a plug for the Interoperability Matters Leadership Council as well under Sequoia, that's really focusing, one of their work groups has focused a lot of attention around the whole data usability question, which is a big issue, and the implementation guide that they've developed and development of additional use cases around that. So That's, that is absolutely a big issue that's being focused on. Tim, let me go to you.
Thanks. So yeah, I'd probably double click on a couple of those. I double click on consent in all its various forms. In order to do consent well, you have to do identity well. So, there's some things that stack up. You also have to do patient matching well, or person matching, or client matching, depending on what sector you're in for that. So there's a bunch of foundational basic blocking and tackling that have to be a priority. Data usability is something that we've focused on a long time, over the last decade, and it's been one of the key ingredients to any success we've had. And it's largely been tied to alignment of incentives. Those are carrots or sticks to change work process, because data quality isn't something that's done in isolation. It's actually done in the work process. And so it's a more sophisticated challenge than just saying, put it in the right format. You have to have those processes that actually output actionable information. And this is particularly acute when we leave healthcare. As we go into children's services, community spaces, as bad as we often criticize healthcare, they don't even have ontologies. They don't have like diagnostics codes. They don't have these rich sets of things that healthcare has invested millions and millions of dollars to sort of create over the last handful of decades, and standards. And so a lot of the thing we think, the opportunity is for us, as we sort of spread out and try to do things with healthcare, and solve healthcare interoperability and try to keep people well. We also have to sort of work to find the right pieces of these other standards, of these other ontologies to be able to bring together, because the biggest challenge that I see in front of us is the co-mingling of healthcare data with other non-healthcare sources of information, and having those be actionable, because that's where our big lift is really going to come in the years ahead, by putting these pieces together. And so having the right humility as we go forward into those spaces, and not saying, well, this is how we do it in healthcare and we're right, but also going into those spaces and saying we have learned a few things about scalability and critical mass in this area, is one of the biggest challenges that we have. But it's also where we're going to get big wins in healthcare, because we're going to get, like every other industry, we're going to find that the biggest lift is coming from outside of our space working with us. And that's exciting.
Thanks. Really, very good perspectives. So here's my other follow-up question. Then we're going to go to the audience and see if the audience has any specific questions. Do you feel that healthcare stakeholders understand the value proposition that interoperability has today and in the future state? And how should organizations plan their own interoperability roadmap? Anybody want to start with answering that one? Tim, why don't we ask you? You did a great job on your last point.
Okay. Philosophically, a lot of our emphasis around interoperability has been providing access to information. Okay, we want to get consumers access to their information. And a lot of times when we talk about, if we switch that dialogue and say we want to get consumers to have control over their information, a lot of times the mindset immediately goes to stopping consumer information from flowing to some other destination. I think that those organizations who are the most successful in the next handful of years are going to want to empower consumers to direct where their information goes to be ingested. So for me, I want my own healthcare information so I can give it to the next doctor, the right doctor, or the appropriate service. But a lot of times, information blocking is about sharing, not taking my information in. The incentives aren't aligned to say, take these results from elsewhere and use them. When I show up at a practice and say, what do you mean the lab results didn't find their way over here, or the referral information didn't come over here? I don't want it to be my responsibility to curate and manage all that information. I want to go on my device and I want to move it from my specialist to my primary care physician, and I want it to move right then. And I don't want it to come to me and have me be this intermediary, because I'm paying those other people to sort of do their job. I literally want to move it right then in real time. And I think if folks have a design objective of being able to enable that for interoperability, they're going to win, whether they're at Walmart, whether they're in a pharmacy, or these other locations that people have used to sort of do virtual care and telehealth post the pandemic.
Great. Any other thoughts?
I got to tell you,
Go ahead, Scott.
I want to plus one to Tim's comment here. I think so. If you ask the question, what stakeholders care about this? Patients care. Patients absolutely are activated. Patients don't like the experience they have with their healthcare system today. So they are the most activated. And so that is actually, that's powerful, right? So I think this is core to what individual access services under TEFCA and the Caring Alliance and the activities we're doing with Caring Alliance at Direct Trust believe that since the patient cares the most, to your point, they can have the most impact on the circumstance. Today, they don't have the ability to do that in a way that's very elegant. In fact, it works actually pretty well. Like in the Apple Health app, you can actually connect to multiple, records and get that stuff curated for yourself, as you say. But then, sharing it to someone else, there's so much challenge in trying to figure out exactly what the rules are around how that will work. FTC has expanded the scope of what it is that the health apps need to be thinking about. They need to be thinking about whether or not they're going to be subject to huge fines under the FTC. So this is a very dynamic space, and I think we need, as a community of quasi-rule makers, to figure out how to make the rules that will make people confident about it. Because people are, that is, consumers are like, why can't I just get this data? Why can't I just move this data? What's the problem here? They don't want to think about the differences between HIPAA and FERPA and FTC's realm. They want to just do this stuff. So we need to make sure that nothing bad will happen when they just do it, and that the organizations who are making these connections can feel confident that nothing bad will happen. That's I think the challenge we have, because I think the patients are very, very motivated.
Well, I think that goes back to Dave's point when he was making his remarks as well. Let's not forget about the patient and the consumer. And I go back to what Seema Verma said, about this is about patient access and making this as easy as possible. That's kind of the key here that we're talking about. Michelle, let me go over to you to see if we have any questions from any of the audience as well in our remaining few minutes. We want to give the audience a chance if there's any questions there. And
Thank you, Lee.
Go ahead.
No. Any questions in the audience? This is a shy audience. I think what has resonated, at least for me, is all of us in the room wear multiple hats, but we all, including you guys, we all wear the hat of being a consumer and a patient. And so we all have experienced the struggle. But I appreciate it. I believe it was Tim who talked about what really interoperability should mean. And it's not just about access, but moving to being able to control where your information moves to and through. So I appreciate that. I'm going to query again to see if anyone's, we do have a question. If you can share your name and your question.
Yes, my name is Karen Shields. And my question is, as all of you continue to engage and think about, the whole concept of human-centered design as we build solutions that have the requirements for, the regulations for interoperability, et cetera. I just wanted to put out there this population that keeps popping up in all of the travels that we have around the states, and I work for Gainwell Technologies, and we have a lot of work in a lot of states from the claims perspective, and the population that is burgeoning and the energy around all of those who provide home and community-based care supporters and who have to actually be the care coordinator for their parents or for all of their relatives, their ability to have input into solution design, I think, is a missed opportunity because they are very, very clear, articulate, and pointed about how they think it should look across programs. So I just wanted to offer up that because I just wanted to be the messenger who keeps hearing that to this team who has opportunity to do that. I think that not only are they clear, they're also willing to be a part of the solution. Like they come from places, a lot of them, especially even in my peer circle. I was just talking to Diane Weiss, who's one of the directors at the National Association of Medicaid Directors, and she and I are talking about starting a support group for people who are providing care for loved ones and reversing those roles. And so just know that people like us are interested in trying to figure out like what would the support and the tools and any solutions that would help this very, very large and completely engaged community, figure out how to help you get to a better place with an interoperable solution.
So maybe I'll go first.
The message is well taken, and I would say that we've had, amongst this entire panel, we've had a lot of conversations around, care coordination, et cetera. I can only tell you that it's absolutely one that's being taken into very strong consideration on how we look to address care coordinators, because it's happening all over. We've seen the use cases, for example, where somebody's going through cancer treatment and really can't be an advocate for themselves. So, you need to have the ability for somebody to be that care coordinator, to be able to coordinate their care with all of the various individuals that are part of that care coordination. So, point is well taken. Thank you very much for your message.
We call that coordinating the care coordinators. It turns out that that's actually a non-trivial activity, and there are few voices in that care coordination circle that need to be listened to, and I think you've identified one of them for sure.
Yeah, I
And
think.
this is Mary.
Go ahead.
Just real quickly, we just completed a study, and we convened a group of caregivers and patients in our Consumer Voices group, and we're publishing the recommendations from that group. These are not health IT insiders. These are people from all walks of life all around the U.S., and their findings echoed exactly what you said, and we are woefully ill prepared to serve them.
Yeah, I would just argue that the biggest challenge in this problem is identity and the identity of the relationship. So these are two very complicated things to manage, and I think establishing those in trustworthy ways, and who can establish such relationships? We've got guardrails we need to build, and we've also got lots of infrastructure we need to build in support of that stuff.
Michelle, any other questions?
Do we have any final questions? I would just have a request for each of you, because we're going to put up the presentations that were provided today, and so in the absence of presentations, if there's a one-page or whatever it is that you put out regularly on your organization that would be useful to this audience. I think all of you have, you're playing key roles, and as we evolve our ecosystem here, there's tons of questions. So the ability to know who on this panel to reach out to for what, if you could send that to us, I would greatly appreciate it. And the only final request/requirement is for you guys to join us in person next year. Even though, of course, this is a digital conference, we want to see you and welcome you to the USVI. But we do appreciate you and your expertise. Thank you all.
And thanks to our panel, Avinash, Jim, Marianne, Scott, Dave, thanks very much. And Michelle, thank you very much. And thanks to all of you and the Governor for having us.
Thank you again.
Take care.
Okay, so we've gotten to lunch. I'm not going to say much. I'm sure everybody's hungry. You can smell the food and hear the clinking of forks. So we will be back. Are we on time, Brad? For